Give it to me.
Live stream.
So the mother that goes on before that one.
Yeah. And praise.
But that's all wrapped up.
Absolutely.
Yeah. It's too long.
Alright.
Margarita.
So this is a live thing there from YouTube. So this is how it look on YouTube right now. This is all you're seeing right now on YouTube.
Audio tied in also.
We need to send out person's link. When you finish, we'll do that.
There are two mute your phones if they're around it.
You just tied into the GoTo right now, right?
Yeah.
We're starting now, right? So the mic is on here, right? I talk at normal tones and everybody hears me.
Yeah, man.
But I might them don't want to use the snowball. But more sensitive.
Hold on a second.
As I was glitching it before, it keeps on putting up that sign. So just press OK. Something about the device. Just press OK.
$191, $192.
So there's sensor.
People logged in. You unplug my mouse.
Yeah, man, plug in over here.
So somebody you guys be sitting here?
Yeah, man, we're going to this side.
Okay.
And then go to meeting. Screen. Alright,
Alright, so what about the people? Since different people using the how we going power seamlessly without showing that you're moving, you'll just move it.
yeah, man, this is what they see now. So when the speaker is finished speaking, we'll just transition to this screen right here. And then we'll transition back to the presentation screen.
Alright, okay. From 10:30 guys. Come. Big shot.
Who's presenting first?
I'm the moderator. I'm starting.
So, you see right here.
I'll take off my mask and I'll say what go on.
Yeah.
What's wrong?
So,
Please apologize for the late start from me, please.
Yeah, man.
moving to you.
And we're late because we're oversubscribed. Had to change the platform.
That we cannot work.
Give me a favor.
Eh?
Hold on. You forgot. You plug the mount out of this? Why is that?
Because I'm using it.
So, Welly, Dr. Welly, you're gonna ask Ideal to pray. I'm should ask Ideal to pray before you welcome.
Pray.
Eh?
Pray for us. So where is he?
I will ask him.
Be there.
He's not this guy for the grade, right? That's all right. That's all.
Here it is for me, go ahead. Activate that for me.
This is your phone?
Nobody can charge you.
Alright, so what you do? Enable back is the mic for me. Snowball.
Okay.
That mic?
Yeah.
So I don't touch anything, right? Ready now?
Well, I don't know. I'm not to switch to that card. The mic itself is sufficient.
It's good.
Yeah, man.
That better.
Because I already have it set up everywhere for that right there.
Because you have to change all of the settings.
Yeah, so OBS, let them seen. Alright.
Ready?
Ready, I know I never.
Yeah, man, ready.
I think you have to. Ready.
Dr. Brown, Ideal.
We don't share our screen, we just share an application, anything. Like here the option or button, we click share screen, we share either the application or the whole screen.
Something keeps plugging out and plugging in. What's it?
It's my computer.
Okay.
So as soon as I Ideal Brown,
So, It's very important now. Right? When the speaker is talking and the speaker finish, we switch OBS first, and then we can do whatever we want to go to meeting afterwards. Alright?
So you bring
No,
up
man, I
OBS.
think I might master.
No, we're not bring up OBS. We use the keyboard shortcut.
You know, I think I
Control
forgot.
Alt and 1.
Control Alt and 2. It hides it.
He needs to just bulk a bit further. I would say. I'll keep on his, I'll keep on him.
Sure, you know what's there.
It's there.
So forward.
We have 2 sessions, so we can do the next one. Ready? Ready, let's go.
Wait, that is there.
Wait, put on my glasses.
Ready? Turn the screen so we can see the thing there, the YouTube screen. Yes, I understand.
Can I start, guys?
The go-to meeting can hold everybody so far.
The camera is off and the mic is off, right? Ready?
Wait a second. Wait.
Good morning, ladies and gentlemen, and welcome to the 13th Annual Kingston Public Hospital Research Conference. I am Dr. Hugh Wang, and I will be your guide through the first session of what will be an enthralling and exciting program. Is everybody hearing me?
Yes.
I apologize for what is a late start due to what I would say was oversubscription and a problem with the platform. But as all things must happen, we will press on. The talks we have for you today are based on the theme Infectious Diseases, a Re-Emerging Threat, as we face the reality of that infection, of which I'm not going to say today. However, we at KPH are cognizant of the work of our staff are doing, so we have also thrown in a presentation by Dr. Jason Copeland on his well-needed intervention in the care of breast cancer. His presentation occurs in the second session. We are honored to have Dr. Alfredo Walker as our special guest speaker. He will be ably introduced by the second moderator, but I wish to state that a decision was made at the inception of the annual conferences on the spurring of our former Senior Medical Officer, Dr. Patrick Bursing, that we invite UWI graduates as our guest speakers. We continue in this tradition with Dr. Walker speaking to us today. We are also blessed to have a sterling set of sponsors who have aligned themselves with an excellent product and who have seen it fit to keep supporting this conference year after year. Let us all support them. I will now start the program by asking Dr. Edel Brown, former chairman of the Kingston Public Hospital Conference Committee, to give a few words of prayer, after which Dr. Natalie Wiley, our current Senior Medical Officer of the KPH, will make her remarks. Thank you.
Ladies and gentlemen, let us pray. Father, we want to give you thanks for this day. It is a day that you have made, and we have purpose in our heart that we will rejoice and we will be glad in it. Thank you that you are the Spirit of wisdom. Thank you that you are the one who has caused us to study, to understand the things in the universe. Thank you that you have already clearly stated in your word that these days will come when we will have pandemics and epidemics, along with so many other things of climate change. And so, Father, we thank you that you are the one that has prepared our minds. And even today, as we speak about infections and infection control, we know that you are the one who's able to give us insights into bringing the solutions to these evils. We thank you, we praise you, we salute you. I pray that your Spirit will speak through every speaker and that every listening ear will be blessed. Thank you for your angels that surround us. Thank you for the messages that will be released. And thank you for those who have ears to hear. We thank you, Father. You have spoken about those who have eyes that cannot see and ears that cannot hear and hearts that cannot understand. But I thank you that today you will reverse that. And we ask and seal that in the name of Jesus Christ. Amen.
Very looking flawless.
Colleagues and friends, ladies and gentlemen, good morning. It is an honor and a pleasure for me to welcome you to the 13th Annual Clinical and Scientific Conference of the Kingston Public Hospital. This year's theme, a re-emerging threat, infectious diseases, a re-emerging threat, could not have been more appropriate as the entire world has been transformed by this COVID-19 pandemic. And the resultant changes regarding infection prevention and control and the way of life, livelihoods, and economies has transformed every single thing that the entire world does. No individual or country has not been disrupted by this infectious disease. The Kingston Public Hospital began preparations for the pandemic in late January of this year. The first patient was admitted in early March, and this virus has upended the health systems in some of the world's wealthiest nations. And in spite of that, the hospital has managed to respond to the challenges of managing patients with COVID-19 while simultaneously continuing to deliver health care to Jamaicans. The Kingston Public Hospital continues to be the main provider of secondary care in the public healthcare delivery system in the island of Jamaica. And we continue to extend our care to Jamaicans who live in the English-speaking Caribbean and Jamaicans who reside in the greater diaspora. KPH remains a final referral hospital for the island of Jamaica. The hospital continues to enjoy an enviable position not only as a service hospital, but in spite of COVID-19 and the challenges We remain a major center for research and training of medical, nursing, pharmacy, physiotherapy, and all of the other paramedical specialists at an undergraduate and postgraduate level. Our annual research and clinical conference showcases original research which has been undertaken at KPH. And this year we are honored to have as our keynote speaker for this year my friend Dr. Alfredo Walker, who is a graduate of the University of the West Indies. He is a forensic pathologist, a coroner of Eastern Ontario Regional Pathology Unit in Ottawa, Canada. Dr. Walker is an internationally distinguished forensic pathologist and clinical teacher, and he has additionally been instrumental in the development of forensic pathology in the Caribbean. The organizing committee of this, the 13th staging of the annual research and clinical conference, which is chaired this year by Dr. Rene Badreau, must again be congratulated and commended for another successful conference, despite our technological challenges this morning, because we've had to make adjustments, including changing the conference format to a virtual one. I wish to applaud the presenters for the tremendous efforts in presenting their research again this year. Finally, I wish for the organizers and the sponsors another successful conference, and I myself am looking forward to learning and benefiting from the presentations. Thank you.
Plug up this.
Great again, go ahead. Too much pauses in between.
Careful this cable. Plug it in.
Too much pause in between. Thank you, Dr. Wiley and Dr. Brown. Our next speaker is Ms. Maureen Golding, our Regional Director of the Southeastern Regional Health Authority. She will now bring her remarks.
I don't know how much time we can get to do other stuff real quick.
5 minutes. It's not long. Okay. Good morning, everyone. Let me first give honor to the Most High God for sparing our lives to be here this morning. It is indeed a pleasure and honor to be here to give remarks. I have always been puzzled yet amazed by the crushing impact of microorganisms on human beings, though impossible to be seen with the naked eyes. These impacts range not just from the pathophysiological effects, such as triggering a large-scale immune response, but also tumbling the greatest economies, forcing innovations, and causing us to reinvent ourselves over and over again. From the dark era of smallpox and cholera to the novel coronavirus, it's like deja vu. Gustav Henle in 1840 reported that infectious diseases are caused by minute living organisms, which in my view has set the tone for mankind's greatest war, which I would call the war against the invisible. This is primarily why this year's theme, infectious diseases, a re-emerging threat, is of such great meaning to me even as a non-clinician. If you are attacked by an angry man with a machete, a sharp machete, at least you can run. But if you're being swarmed by tundra of Vibrio cholerae, you are pretty helpless. According to recent news, COVID 19 has killed approximately 1.4 million people. The World Health Organization reports that infectious diseases are among the top 10 causes of death globally. 3 are infectious diseases. In light of the continuous emergence of infections, the burden of infectious diseases is expected to become even greater in the near future. It is against this backdrop that I would like to laud Dr. Patrick Borising for his brilliance in initiating this conference in 2007, as well as to commend the courage of Dr. Yu Wang for keeping its heart beating over the years. On behalf of a grateful nation, I would like to express our most sincere gratitude to you all for risking your lives to save the lives of our nation's men and women, boys and girls. As I close, it was Sun Tzu in his work titled The Heart of War who said, "In the midst of chaos, there is also opportunity." Though our accident and emergency departments are overcrowded, ladies and gentlemen, though the struggle is very, very real on the front line, I want to challenge you today to keep reinventing yourselves as professionals. One day, I hope to see a Nobel Prize winner coming from Jamaica, and it is possible, yes, we can. I have no doubt that this conference will offer a rich and exciting insight into infectious diseases. Thank you.
What's the next step?
If you're not experiencing problems with the audio, you need to go to audio settings and switch to audio, or someone is pasting the YouTube link so they can view it on YouTube.
YouTube link is being pasted.
Yes, the YouTube link is in the chat.
Go to audio settings and do what?
And then switch the audio to speaker. Or better yet, send them to the YouTube link. If you're having any issues, it's on YouTube.
Okay. 1 second. This next. Brown. Okay, ready?
Man, I'm going to play away from the flight.
Ready? Ready? Time out. Thank you, Ms. Golding, for those words. We are now going into our clinical presentations. And first, we'd like to make note that our first two speakers are from anesthesia. I've been told, warned off, if I don't mention this, I can't go back to work. So our first presenter is Dr. Jody Ann Brown, who is a highly motivated and dedicated medical officer who is well known in their anesthetic department and works efficiently as well in bringing care to her patients. She's a UWI graduate and she is now a medical officer in the Department of Anesthesia Intensive Care. She will be presenting to us Outthreat New Disease. Thank you, Dr. Brown.
Is that open presentation? Perfect. I can't sit down, man. That it can't, it's supposed to be retired if I speak from it. You're just starting from it. Okay.
No, they're supposed to see it as well, Ella. You hear? They're supposed to see it as well. I just want mine for convenience, but it's supposed to be sent.
Right here.
Outthreat new disease.
What's his name?
Outthreat new disease. But I don't really. You have two of them there.
Only computers can hear me. Can try it.
Should try YouTube. Is that the combo? You know, look at the little man that come for you.
Please mute your speakers, your microphones rather.
I'm talking about microphone and people care to sing.
I look like a participant, just say something. Look like a participant, just say something.
Oh.
Oh, no, wait. Like you connected.
Am I connected? I just saw my social.
Please mute your mics.
All right, good morning again, everyone. So going over, I will be presenting the first part of a presentation from the intensive care unit at the Kingston Public Hospital. We'll be looking at old threat, new disease as it relates to COVID-19 infection. So the objectives of the presentation will be to first discuss the role of the management of ICU in patients presenting with COVID-19. We'll also look at a case study and will then describe the threats that are oftentimes associated with COVID-19 and the persons who these threats will likely affect. So in terms of the severity of the disease, so oftentimes patients who are presenting or who being managed by ICU are patients who will be classified as either having severe or critical disease. And this includes patients who either have difficulty breathing, patients who have fast respiratory rates, patients who have issues with oxygen saturations, or patients who have significant findings on chest radiograph. This also includes patients who have had significant failure as a result of their disease process and patients who have significant hemodynamic compromise. Now, who gets referred to ICU? So as mentioned before, these are oftentimes patients who are classified as either having either severe or critical disease. But strictly speaking, in an ideal setting, any patient who has been admitted with a diagnosis of SARI requiring oxygen therapy should really be reviewed by the intensive care unit team. Additionally, any patient who requires any significant amount of organ system support should also be seen. So in terms of the goals of ICU management for the patient presenting with COVID-19, so the main aims are to prevent infection and to prevent the spread of infection, especially as it relates to the team members. There's also the etiologic treatment, oxygen therapy, and respiratory support, which tends to be the main arm of the care that we give. There's hemodynamic management, fluid management. There are also the aspects of psychological care, immunity therapy, prevention of secondary infection, as well as the management of any associated issues with COVID-19, and this includes coagulopathy as well as acute kidney injury. Now, in terms of the usual algorithm that can be used in the provision of respiratory support for patients presenting with COVID-19, so they can be broken down into patients who either have significant issues with oxygenation, as evidenced by findings on your usual arterial blood gas, or it may be based on the patient's clinical findings. So usually in terms of what we are able to provide in terms of support, it falls in the realms of either high flow nasal oxygen or non-invasive intubation, or the patient may require intubation and mechanical ventilation. Now, how do you know who to refer to ICU?
No, but
Other than the
if you
clinical
do,
findings,
you're making.
there are certain prognostication tools that may be used, and of these, the more common or the most common is one which is called the 4C score. Now, this score was developed by Knight et al. In this year, and it really is a risk stratification of patients who are admitted to the hospital with COVID-19, and it uses 8 parameters and basically determines if it is that the patient is likely to demise during their hospital stay. So in terms of the factors that are used, so we look at the patient's age, the patient's sex, the comorbidities that the patient has, the patient's respiratory rate on presentation to hospital, the oxygen saturation, the Glasgow Coma scale, as well as the biochemical parameters, including the blood urea nitrogen, as well as the C-reactive protein. Now, there's a score that is given for each of these parameters, and the highest score based on the summation of all of the individual scores will then determine the patient's mortality. So in terms of your risk score, there are 3 or 4 other possibilities. The patient may be deemed as either low risk, intermediate, high, or very high risk. Oftentimes, the patients who we will be seeing in the intensive care unit are those who are either deemed as having either high or very high risk of death. Now, there were recognized limitations of this study. 3 of the main ones were that they were unable to evaluate the predictive performance of scores that used larger numbers. So from a comparison standpoint, they really were unable to see if it is that the 4C score had better predictive values. From the standpoint of being able to predict using scores that either had parameters that were infrequently measured or parameters that required CT findings, they also were unable to compare these scores to the 4C score. And of course, there was no inclusion of patients who had chronic illnesses such as hypertension, or those who had a previous history of myocardial infarction or stroke. And of course, in our population, oftentimes we have patients presenting
You
with
entered
these issues.
no digits. Please re-enter your access code followed by the pound or hash sign.
Patient presenting with COVID-19 is your neutrophil lymphocyte ratio. And as we move further down in the presentation, we'll see how this becomes important. Now, there are several different grades or classifications that may come up using your neutrophil lymphocyte ratio, and more often than not, once the patient gets to a ratio of 9 and above, then the patient tends to have a worsened prognosis. Now, looking at our case study, so this patient presented on September the 4th of this year, a 53-year-old Mason, not known to have any chronic illnesses. On presentation to the hospital, he had a 3-day history of fever, as well as a cough that was productive of yellow sputum. As it relates to his vital signs on presentation, the patient was febrile, had a relatively increased heart rate. However, respiratory rate was noted to be within normal range. Saturation of note was also reduced, but the patient was awake and conscious. Now, in terms of the chest radiograph findings, they were noted to have bilateral infiltrates, and the patient from that point was assessed as having a lower respiratory tract infection with a diagnosis of SARI to rule out COVID-19 infection. So he was admitted to the internal medicine ward where he was treated with antipyretics as well as antibiotic therapy commenced, and a COVID swab was subsequently ordered. Additional investigations were also done for the patient. In particular, he had a complete blood count done, as well as urea and electrolytes. A D-dimer was done, as well as troponin T and other coagulation parameters. Now, on day 1 of the admission, which would have been day 4 of the patient's symptoms, the patient was noted to be now hypoxic on room air. Remember, he would have originally presented with a saturation of 95%. This would have fallen to 86%, and the respiratory rate as well would have gone up to 22 breaths per minute. In terms of the admitting labs at that point in time, of note, the white cell count was elevated at 14.7, and as it relates to the neutrophil and lymphocyte count, the lymphocyte in particular was quite reduced. As it relates to his urea and electrolytes, significant issues would have been a mild hyponatremia as well as an elevated creatinine level. Now, based on the values that we would have had for the patient on presentation, a calculated 4C score wouldn't have been possible as the admitting CRP was not available. However, based on the other parameters, the 3 possible scores for this patient would have been either 3, 4, or 5, meaning for this patient, the highest 4C score that they could have obtained would have been a 5, which puts them at intermediate risk as it relates to their mortality. Now, on day 2 of admission for the patient was noted to have increasing oxygen requirements. The saturation at that point in time would have also fallen. The vital signs otherwise, though, remained stable. As it relates to the patient's symptomatology, the patient had complained of feeling awful at that point in time, and the COVID swab was done. On day 3 of admission, the patient had remained febrile. Other vital signs, however, had remained stable, and based on the finding of an elevated D-dimer from the admitting blood investigations, the patient was started on plexane therapy. By day 4 of admission, the patient would have been referred to ICU, and this would have been as a result of increasing oxygen requirements and an arterial blood gas showing an reduction in terms of the oxygenation. The patient was assessed as having SARI with hypoxic respiratory failure, and at this point in time, high flow nasal oxygen was commenced with a flow rate of 60 liters and a FiO2 of 0.9. By day 5 of admission, the patient had remained febrile. The respiratory rate, however, had gone up, and the saturation was still low despite the start of high-flow nasal oxygen. Now, in terms of the review of the patient by the intensive care unit team, at that point, the patient would have been observed from a distance, and this was due to the unavailability of appropriate N95 masks. The patient was noted to be lying comfortably in bed. However, adjustments were made to the patient's high-flow nasal oxygen parameters based on the previous saturation. Patient had also reported feeling better. During that same period, the patient subsequently developed worsening in terms of the saturation, with saturations falling to 77%, despite adjustments in terms of the flow rate. The lab investigations had also shown an increasing white cell count. So blood investigations had also shown an increase in white cell count from the admitting value of 14 to the null value of 22. As well as a prerenal azotemia, and at that point in time, the decision was made to transfer the patient to the intensive care unit with the availability of space, and this would be to facilitate the starting of non-invasive respiratory support as well as monitoring. By day 6 to 10 of admission, the patient had continued ICU care in the form of high-flow nasal oxygen, and this was alternated with non-invasive ventilation. The patient continued to receive hemodynamic support and had shown improvement in the peripheral saturations, as well as the partial pressure of oxygen on serial ABGs that were done. Now, by day 10 of the admission, the patient had now started to show improvement in terms of the oxygenation. However, there was a transient period during which the patient was noted to have desaturation, significant enough desaturation, down to 65%, and at this point in time required continuous non-invasive therapy. The thought process at the time was whether or not the patient had developed a thromboembolic phenomena as a complication of their COVID-19 infection. And in addition to the non-invasive ventilation, self-proning was instituted to assist with the improvement in oxygenation. By day 11 of the patient's admission, we had received the results from the nasopharyngeal swab previously done, which had shown the patient to be COVID-19 positive. This would have been 9 days after the initial swab was taken. By this point in time, we were able to wean the patient in terms of oxygen support to 8 liters via simple face mask. Other supportive measures were instituted, but based on the improvement on the patient's saturation and other parameters, the decision was made to transfer to the ward. Now, while on the ward, the patient continued to receive oxygen support, with weaning successfully happening, with discharge home 21 days after initial presentation to hospital. The patient was discharged home on Xarelto for a presumed pulmonary embolism, with the plan for an outpatient investigation in the form of a CT chest and clinic review. Now, as it relates to the outcome of this patient, the patient would have spent 10 days in terms of ICU admission, with home discharge occurring 21 days after admission to the hospital. The patient was seen in the medicine outpatient department on the 11th of this month, which would have been 17 days post-discharge, and at that time had remained stable and clinically well. The CTPA, which was also done for the patient for investigation of the pulmonary embolism, was also negative, and at that point in time, therapy with Xarelto was discontinued. So on this occasion, there was a happy ending as it relates to the overall survival, though, for patients presenting to the intensive care unit. From a KPH perspective, at least, the survival in these patients is really 40%. 60% mortality is what we have been observing for patients who, at any point in time, require either support or admission to the intensive care unit. So, of course, the journey continues. So we'll now be looking at the threats in this new pandemic. So yes, a new pandemic, however, are these threats really new? So a threat is defined as any So a threat is defined as any person or thing that is likely to cause damage or danger. And of course, corona is certainly that. Now, what are the threats that we are less aware of as it relates to the COVID-19 infection? And what is the impact that it has on our care and conduct? Now, in terms of the threats, so the relevant players, we have the staff, the persons who are actually looking after the care of these patients. We have the patient who is affected, and we also have the family members as well as other patients who may be in the vicinity of the affected patient. Now, in terms of the threats that we may see, so we have the threat of fear, we have the threat of misinformation, and also the threat of resource depletion. Now, as you can imagine, these threats are not new, but in the face of COVID-19, there may be a new twist as it relates to how we're able to manage these threats. Now, the concerns for the affected groups, including infection, and this is either infection for the staff themselves or infection for other family members. There's also the threat of isolation, and this is as it relates to the patients themselves, if it is that they require isolation post their diagnosis or on suspicion of infection, and of course, isolation as it relates to team members who may possibly become exposed or infected with COVID-19. There's also the threat of discrimination. Oftentimes, and a lot of times related to lack of understanding, there's a discrimination as it relates to the patients who are infected, and this may impact care of these patients. There's a threat of testing. The actual testing process itself can sometimes generate fear. There's also the fear of not knowing enough, and the fear, of course, of knowing too much for those persons who would be bombarded, and we'll look a bit at that later on. Now, a study that was carried out by Dubé et al. Looked at the psychosocial impact of COVID-19, and what it really found out is that there is now a new phenomenon called coronaphobia, which is where there is just widespread fear of having the infection, widespread fear of being exposed to persons who are infected. What they found is that there is a significant psychosocial impact, with healthcare workers being the highest risk of infection, with the consequent negative psychosocial effects. Now, this includes the increased risk of burnout, the increased risk of substance abuse, post-traumatic stress disorder, and feelings of either being inadequate or feelings of overwhelm. So as a group, do we really know what to do if it is that we think that we need help if we're suffering from any of these symptoms? Now, as it relates to what is being done on an international standpoint, the CDC has released information as it relates to resources for patients, or for persons rather, who may be dealing with these psychosocial issues. However, from a local standpoint, certainly within this region, we have been, or information has been made available in the event that we do want to reach out. So some improvement as it relates to what we're able to do if it is that we find ourselves in this situation. Now, in terms of the threat of resource depletion, as we would have seen internationally, there's a threat of resource depletion in many areas, right? Now, the biggest issue coming out of that would be the threat of limited availability of protective personal equipment. Now, as it relates to your personal protective equipment, this includes more than just an N95 mask. And yes, we have had an increase in terms of the donations of these. However, there is also the concern of whether or not these are masks that are appropriately fitted, masks that are really sturdy enough to withstand whatever it is that is required. Now, in terms of your interaction with patients, so as it would have been mentioned during the case presentation, on one occasion when the patient needed to be reviewed, the patient had to be observed from a distance. And this would have been owing to the lack of available N95 masks at that point in time. Now, in general, in terms of the care of the critically ill patient who is infected with COVID-19, these patients tend to require a greater contact time or frequency of contact. In addition to that, there is also the need for what is so-called a body system, so as to allow for proper donning and doffing of the personal protective gear. Now, with that, there is increased use and increased requirement of these equipment. So, of course, if it is that there is any kind of significant shortage, and this may impact the care that is being provided for these patients. Now, the other limitations that we are able to see, or the other limitations that we have seen, include lack of manpower, or limitations in terms of manpower. And this is not just as it relates to your healthcare workers, but also in terms of your auxiliary staff. Remembering that oftentimes patients who are admitted to the intensive care unit will need additional treatment strategies, such as the movement of patients, placing patients in the prone position, and this requires an additional amount of staff. Now, the other limitations that we may observe, or that we have observed, are limitations in terms of available radiologic investigations as well as special investigations. Now, if you remember from the case presentation, when the patient had presented, a C-reactive protein was requested. However, because of lack of availability, that result would have not been made available. And so from that, limitations in terms of being able to provide a prognostic score for this patient, or these patients, are sometimes affected. On discharge, the patient was also requested to have a CTPA done as an outpatient. Now, in a typical setting, you should be able to get certain investigations, and of course, if it is that there is any kind of hindrance to that, then it may impact the care that you're able to provide to the patient, whether during their stay in hospital or once they have been discharged home. Now, the question is is there a significant delay in terms of the care that we are able to provide for these patients given the limitations? We certainly have seen an improvement in terms of the available lab investigations, especially your special investigations, and especially as it relates to the timing with which these investigations are made available so that appropriate treatment protocols can be put in place. Now, in terms of the other threats, or some of the threats that we may be seeing internationally at least, there has been an interruption overall in some of the services caused by the COVID-19 pandemic. Now, this tends to affect the overall health of the patients who are seeing, especially with patients who have non-communicable diseases such as those with hypertension and diabetes. With the interruption of our primary care services, the question is, are these patients at a disadvantage? Will these patients present with a worsening of their condition? Or if infected with COVID-19, how will these patients be able to manage? Now, our particular case study, this patient had no chronic illnesses. However, if it is that this patient had chronic illnesses, and we have had patients presenting with hypertension, diabetes, significant cardiovascular disease, these patients tend to do worse. And we wonder, are there issues or is there a correlation between the lack of available primary care with how these patients tend to present? Now, the other question is, will we see a resurgence of communicable diseases, particularly diseases that would have been previously covered by a normal vaccination schedule? Now, information has been released by the WHO as it relates to warnings and cautions, especially for infections such as your polio infection. And that is something to really look out for in the near future. Now, as it relates to threats as misinformation, now the other phase of this pandemic is that of the infodemic, and this really speaks to the surplus of legitimate information as well as misinformation that exists surrounding COVID-19. Now, it is oftentimes fueled essentially by unregulated social media as well as positive reinforcement given to likes versus accuracy. So the question is, who is really providing the information? Oftentimes, we will see information being provided by persons who are popular, so to speak, in social media, as opposed to persons who have accurate information and who can guide the public as it relates to the disease process. Now, academic journals have also been contributing to this, and this is due to the rapid turnover of papers. In some circumstances, these papers have not been subjected to the usual rigors of peer analysis that we would have seen. So the infodemic itself undermines the efforts of the chances or the attempts to mitigate the effects of COVID-19, especially as it relates to the psychosocial impact. Now, another study that was looked at 38 million articles that were published as it relates to COVID-19 infection between January and May of this year showed that there was significant amount of misinformation, especially as it related to infection and treatment of the infection itself. As you can see from the table here, we have 46.6% of information that was actually provided that was in the form of either misinformation, threats, or conspiracy theories. Now, in terms of the consequences of misinformation, this includes person engaging in either harmful cures or patients not adhering to scientific evidence-based recommendations such as social distancing. There's also the question of whether or not it impacts the time with which the patient presents to hospital. Or a particular patient presented to hospital within 3 days of onset of symptoms. But we have seen situations where patients will present after possibly a week of home therapy or of just not presenting to hospital. And this, of course, impacts the prognosis of the patient and the care that we are able to provide at that particular point in time. These patients as well oftentimes end up being admitted to the intensive care unit because of progression of the disease process and complications in terms of organ system failure. Now, there's also the question of are these or is this misinformation being spread with nefarious reasons in place? Of course, on an international standpoint, we can see a lot of protests being involved as it relates to the wearing of masks and whether or not the virus itself is contagious. But certainly on a local standpoint, we have no lack of that happening. Now, overall, the question is, are these threats really new? Now, if you recall the polio pandemic or epidemic rather of the 1950s, these same threats were really about. Now, in general, yes, America was deemed to be polio-free over 25 years ago, with the most recent outbreak being in 1982. However, as it relates to the shifting of the concerns now to infection with COVID-19 and the impact that that has, particularly on primary care. The question is, will we see a resurgence of these infections, one, and two? These same old threats, will they again become an issue as it relates to disease processes that we would have previously seen? And is it that we're going to be having any kind of significant shifts as it relates to the social as well as the economic costs that are associated with this? No, in terms of what we can do. So despite the pandemic, we are continuing to offer the best service that we can. Of course, once a patient presents, and if it is that there is an indication, patient will, of course, be offered intensive care unit care. However, we do need to take a look at the necessary or the relevant threats and how this impacts our care, and understand that this can greatly affect the patient's prognosis. It definitely cannot be business as usual, and a greater need for communication is needed as it relates to team members, staff, between team members, and also between the team members and the patients, and offering of greater psychosocial support, especially to patients who are affected, family members, and also staff members, especially those who are in direct communication with these affected patients. But we do continue to be judicious as well as ethical in our use and distribution of our resources, and we guard against misinformation as well as hysteria, and we do look forward to a renewed and resilient future. Thank you.
Okay. Thank.
You can see yourself for a couple of seconds. Just wait a little bit. Mike. What is going on with this Mike and go to meeting? Okay, so.
Thank you, Dr. Brown, for that stimulating talk on what KPH, ICU, and anesthesia is doing for the care of our severely ill COVID-19 patients. Let us not fool ourselves. COVID-19, I didn't want to say the word, but COVID-19 is affecting us and we should still continue to take it very seriously as it is reflected in our full ICUs and our full wards. So thank you very much, Dr. Brown, for that presentation. I'd like to take this time before I introduce our next speaker to thank our sponsors, Lakis, Boringa Ingelheim, the National Health Fund, Facey Commodities, About Nutrition, the Caribbean School of Medical Sciences, PA Benjamin, Apex, Imaging Association, and Apex Medical Global. So, Alpha Medical Global, my apologies. So, thank our sponsors. Without them, this would not be possible. Okay, so here where the apologies start. To ladies and gentlemen, there who are tuned into our presentations, I would like to sincerely apologize for the severe technical problems that we are having. Our platforms seem to be having some conflicts, and I urge you right now to look in the GoTo chat, and you will see a link to go to YouTube. There's a YouTube link posted in the GoTo chat and also in the WhatsApp chat. Failing this, you can just go to YouTube. Most people have a YouTube account, and type in KPH Conference Live, and you'll be able to access this current platform. We're having interruptions in our presentations because there's a conflict between one platform that we started with, and to expand our coverage to other people's logging on, we had to go to YouTube, and there's a conflict. So bear with us. The talks are coming up fast and furious. So if you give us a few, are we ready? Yes. So at this time, I'd like to introduce Dr. Kinney Lee, who gave me a brief thing to speak to her. So I might just stretch it out a little bit just to get her angry with me. But she's a career anesthetist, young in her career, but after internship, she worked in anesthesia and intensive care for 3 years, and she's now in her first year of the DAME program in anesthesia and intensive care. So without further ado, we'll ask Dr. Kinney Lee to come and make her presentation. Right, so just reiterating before she takes her position, for you to go to YouTube, type in KPH Conference Live, or just check the chat and the link to YouTube is there. Okay?
Oh my gosh. So. Ready?
Oh, okay. Keep scrolling. You can't make it go to the okay. All right. Hi. Oh, okay. All right. Hi. Good morning, everyone. Dr. Kenny Lee. I'll be continuing from what Dr. Brown was previously speaking on. We're going to start off with new threats, old disease. So as we all know, since the advent of COVID-19 in December of 2019, there have been many studies that have been published as it relates to the treatment of coronavirus, as well as the pathophysiology, symptoms, and signs that we should look out for. Many of these have been discredited. However, quite a few of these studies have held some merit. Internationally, the studies have suggested that admissions for thromboembolic conditions have increased in this time of pandemic. In some studies, more specifically Mondal S. et al., the incidence is as high as 31% in patients admitted with COVID-19. The pathophysiology is suggestive of hypercoagulability and overproduction of pro-inflammatory cytokines, which is better known to us as cytokine storm.
This leads to venous as well as arterial thrombosis. In this study, it was noted that the venous thrombosis was more common than the arterial thrombi. In several reports, these are the terminal blow delivered in patients afflicted with this virus. Moving on, I'm going to speak about the ICU KPH experience. All right, so a review of ICU admissions in KPH in both 2019 and 2020 was undertaken to determine if we had observed an increased number of patients with thromboembolic disease. Our methodology that was undertaken. So what we did, we used our ICU admission logbook to identify the patients admitted between January and September of both 2019 and 2020. The diagnosis and demographic data were also noted. Bearing in mind that our ICU was closed for approximately 3 weeks in August due to a large-scale exposure of our staff members to coronavirus, so consequently, they had to be quarantined. All right, so in the year 2019, we had a total of 201 admissions between January and September. Majority of these were, of course, male at 134, and mostly young people were admitted between the ages of 15 and 39 years. Of this 201 admissions, 56 deaths were noted, bringing the mortality rate to approximately 28%. Also noting that of the 201 admissions, 60 of these cases were trauma-related. Trauma-related being either motorbike or motor vehicle accidents or gunshot wounds. And of course, again, most of our admissions were from the Department of General Surgery. In 2020, similarities were noted. However, we had an increase in our admissions from 201 to 218, again, mostly male. And we had an increase in our mortality rate from the 56 noted in 2019 to 76 noted in 2020, increasing the rate to 35%. And there was an increase in our trauma-related cases from the 60 to 78. This is just a table depicting what I just said so that we can put things into perspective. Right. All right. So, note well, that's our admissions in 2020 between January and September. Most of our admissions were in the summer period between May and July. This also occurred in September, and of course, most of these cases were trauma related, mostly motor vehicle as well as motorbike accidents. Alright, so in looking at our admission diagnosis, patients were grouped into 3 general categories: viral, stroke or cardiac, and sepsis. Alright, so for the years 2019 and 2020, this is a bar graph just comparing the 3 groups that were mentioned previously. As you can see, the sepsis-related cases increased in 2020 when compared to 2019, as well as the cases of the viral cases decreased in 2020 as it relates to 2019, and our incidence of stroke and cardiac disease increased in 2019 as it relates in comparison to 2020. All right, so moving on, noteworthy was there was an increase in the admissions for diabetic ketoacidosis. In 2019, we had 5 admissions versus in 2020 when we had 8. This is a greater than 50% increase for 2020. Unfortunately, at the time that these admissions came in, we were not routinely testing our patients for coronavirus. Therefore, no documentation would have been made in our logbook, which is one of the limitations that we had. So with this information, one cannot help but wonder if there is a link between COVID-19 and diabetes, and if, in fact, DKA is a presentation brought on by SARS-CoV-2. Alright, so literature review. So diabetics have no increased risk of being infected with SARS-CoV-2, as noted by Sewood-Harry and Drucker when they did literature reviews comparing coronavirus to diabetes. The International Diabetes Federation suggests hyperglycemia provides favorable conditions for viral replication. Also noted that hyperglycemia is known to weaken our immune system, thus making it easier for us to contract viral infections. However, the course of disease may be more tumultuous in diabetics, and there are several studies showing increased mortality in persons with COVID-19 who are also diabetic as compared with non-diabetics. Sewood-Harry et al. Observed a higher death rate in diabetics with COVID admitted to ICU as compared to those without comorbidities. And Drucker suggested in persons with pre-existing diabetes and COVID-19 that DKA may be a poor prognostic sign. Alright, so with all this information that has been stated, does coronavirus cause acute diabetes? The pathophysiology does not convincingly answer that question. However, it is suggested by Yang Jin et al. That coronavirus as well as diabetes share similar pathophysiology. Right, so they share similar pathophysiology as it relates to the two proteins, angiotensin 2 converting enzyme as well as dipeptidyl peptidase 4, which are two proteins that are key in the cardiovascular, renal as well as renal system and physiology, as well as the glucose homeostasis. In this same study, Yang et al. Conducted a prospective matched cohort study. 39 patients with SARS who had no diabetes or received no steroids were compared with a matched healthy control. They were followed up for 3 years, and 20 of the 39 patients were diabetic during hospitalization, but only 2 had diabetes at the end of the follow-up period. Alright, so for type 1 diabetes, it has long been implicated that it is linked to viruses, namely the cytomegalovirus, otherwise known as CMV, Epstein-Barr virus, mumps, rotavirus, and Coxsackie virus. Hepatitis B, however, is implicated in type 2 diabetes due to the beta cell dysfunction. A study by Lee et al. Described incidence of ketosis and acidosis in a review of 658 hospitalized patients confirmed with COVID-19. 42% presented with positive urine or serum ketones, and 7% met the DKA criteria according to the American Diabetic Association. Alright, so this is just a flowchart basically depicting the pathophysiology of diabetic ketoacidosis. So as was mentioned before, for the pathophysiology of coronavirus, so there is a surge of pro-inflammatory cytokines, namely interleukin 6, 8, alpha tumor necrosis factor, as well as interleukin 1 beta. This causes an increase in your counter-regulatory hormones as well as a decrease in your insulin. These factors lead to an increase in your glycogenolysis or gluconeogenesis, which cause hyperglycemia. The surge of cytokines can also cause insulin resistance, and the hyperglycemia leads to an osmotic diuresis, which leads to dehydration and electrolyte derangements, often seen in patients with DKA. The decreased insulin as well as the increase in your counter-regulatory hormones also leads to hormone-sensitive lipase activation, which leads to your triglycerides being converted to your free fatty acids, leading to ketone bodies that are picked up in the urine when a urinalysis is done. These excess ketone bodies leads to a metabolic acidosis, which is also seen in patients with diabetic ketoacidosis. All right. So with all this information, again, one cannot help but wonder if coronavirus 2 is diabetogenic. The question whether or not there's alteration in the glucose metabolism leading to worsening pre-existing diabetes, or could it just be a case of a new mechanism? Questions remain. Studies are still being done to answer such questions. Are type 1 or type 2 diabetics more affected? Are patients at higher risk for diabetes or DKA? Does the virus change the natural history for pre-existing diabetics? COVID IAB project has been established to try to answer some of these questions. So in summary, there is an increased number of persons admitted to KPH ICU with DKA that have not been fully explained. Ideally, a more robust study should be conducted, supported by criteria and empiric objective data. The question is intriguing as there may be implications for therapeutic interventions, and it may suggest a greater need for strengthening our primary care prevention programs targeting at-risk groups, namely our diabetics. Thank you.
I'm not going to urge everybody to YouTube.
Thank you, Dr. Lee, for that presentation that focused on some of the medical complications of COVID-19 infections. And in the last part, we looked at diabetes and the incidence of increased incidence of ketoacidosis in patients who were suspected of having COVID-19. We thank her. I gather this is her first major presentation, and she did very well. So if you can applaud her in your private space, thank you very much. Thank you, Dr. Lee. We hope to see you back next year and doing many such presentations and research projects. All goes well for the future of research at KPH. We should be on the program. We should be having our gold sponsor, but we will instead be asking Dr. Sandra McLeod, consultant dermatologist at the National Chest Hospital and KPH, who will be presenting crusted scabies, still a keep in gone nowhere. Now, I think I've known Dr. McLeod all my life, my professional life at least. My professional life. She is a Cummins scholar, and she did her postgraduate studies in dermatology at the St. John's Institute of Dermatology in London, England. After she finished her postgraduate studies, Dr. McLeod worked in the UK, rotating through the disciplines of dermatology, rheumatology, geriatric medicine, and internal medicine before returning home to Jamaica. Since that time, she has been at KPH and has gone nowhere. So we thank her for her dedication and service. She loves to present. She's a constant presenter at these seminars. many years, every year, and we thank her for her interest and her contribution. So without further ado, we'll ask Dr. McLeod to come and present crusted scabies, still a keep. It not gone nowhere. Thank you, Dr. McLeod. Right, I'm asked to remind you to go to the YouTube link that has been posted in the go-to chat as well as your WhatsApp chat groups. All right, and if you're unable to get those links, you can simply log on to your YouTube account and type in KPH Conference Live, and you should get the stream. So, Dr. McLeod.
Alright, so this is a quick run through. So the presentation. And here's the buttons that they use down here. Alright, so all they do is move this down here like a regular computer. Come over a little bit more.
Where's the mic?
The mic is in here.
So they don't really need to see me.
You don't want them to see you? I just need to see a little screen. Right?
Yes, all right.
Anytime you're ready.
Yes, sir. Where's my button to move my slide? I can use this one. Thank you, Dr. Wong, for that introduction. And a good morning. I am here to tell you that crusted scabies still a keep, it not gone away. And for the non-Jamaicans, this means it's still here, it hasn't gone anywhere. So I'll be going through quite a bit of background, so just bear with me to remind you, scabies is an infestation caused by the mite Sarcoptes scabii var hominis. This mite has been phenomenally successful worldwide. This is because it understands its host. It knows we don't like to isolate and that we love to congregate. Transmission is by person-to-person contact primarily, and infested persons normally only have a few mites. Now, the diagnosis is usually clinical with the typical history and lesions and is confirmed by identifying mites and eggs on light microscopy. Now, when you look at this slide, it is uncanny the similarities between scabies and COVID-19. However, scabies patients remain contagious as long as mites are present. No quarantine won't help. Regrettably, previous infestations does not confer any immunity, so you can get it again and again. However, the good news is that adequate treatment results in a cure. In 2017, scabies was added to the World Health Organization list of neglected tropical diseases with good reason. They estimate that over 200 million persons are affected at any one time, a significant economic and health burden. Now, scabies occurs worldwide, but is more common in tropical climates and also in those of lower socioeconomic status. So it's the poorer people in poorer countries who are inordinately affected. There is little research or funding into scabies. Truth is, there is nothing sexy about scabies, so not many takers. A little more history. The mite was first identified in the 17th century, making it one of the earliest links between organism and disease. In the 19th century, the Norwegian pair described crusted scabies, hence the old name. Benzyl benzoate was formulated in the 20th century, 100 years ago. And permethrin and ivermectin are over 50 years old, and there's been no new treatment. So yes, a neglected disease.
Just a little bit about the medications. Permethrin 5% is now the first line treatment, but note the cost, which may be prohibitive if you have a family of 5 to treat and affect compliance. Benzyl benzoate is cheaper and effective, but more irritant. These in yellow are useful adjuncts. The only available oral treatment, ivermectin, is unavailable in Jamaica except for our animals. Now, perhaps this 3-day regime would be familiar to some of you, but somewhere along the line, the application time has been shortened, which is of some concern to me. The Italians, however, have come up with a compromise. Treatment failure can usually be ascribed to inadequate application or reinfestation if all contacts are not treated. That can actually be quite a challenge to get a proper head count. It can also be a hard sell to convince asymptomatic persons to be treated. There is, however, the worrying possibility of permethrin resistance, which I'll say a little bit more about. So on to crusted scabies at last. Crusted scabies is a hyperinfestation with the same scabetic mite, but instead of a few mites, there may be millions and the entire body surface area may be affected with hyperkeratotic crusted plaques and nodules, as in this unfortunate man. It usually occurs in the immunocompromised patients for whatever the reason. So this small study looked at the cases of crusted scabies which presented to the dermatology department since the beginning of this year. Data was retrieved from the medical records. Skin scrapings was done from most of the patients and investigations were requested. So, our results. 10 patients were diagnosed clinically with crusted scabies, of which 8 were confirmed with light microscopy. There was a marked male preponderance, but the reason for that is unclear. The age range spanned decades. But note that almost half the patients could be considered young, so it's not just a disease of the elderly. The duration at presentation ranged from 3 months to 3 years, with 60% having had the condition for 6 months or more, way too long. 80% of cases had significant comorbidities, of which HIV and chronic kidney disease were the most common. 60% of cases were referred from specialist clinics or inpatient referrals. This says 2 things. Firstly, the diagnosis is being missed. And secondly, they are in your clinics, so everyone needs to be aware. 30% of cases were from rural parishes that lack the services of a government dermatologist. Hopefully that is something that could be addressed. Not surprisingly, these patients also tended to present later. Now, this is a spreadsheet of the cases, and I will just highlight a few points. This patient had onycholysis of 1 great toenail. The lifted nail provides safe haven for mites to proliferate undisturbed. So she had regular scabies elsewhere and crusted scabies under 1 toenail. Lesson: treat under the nails. Note that her family was also affected. This patient presented to us in a wheelchair, but gained 10 pounds and actually walked into clinic after treatment with no other intervention, highlighting the catabolic state of the condition. Keep losing my mouse. A patient with crusted scabies in an institutional facility can easily fuel an outbreak, and so that needs to be monitored very carefully and recognized. Patients with CVA may develop crusted scabies due to weakness and reduced ability to scratch. Combine that with topical steroids and that will certainly aggravate matters. I had previously looked at our cases of crusted scabies over a 20-month period, and there were 10 cases, 2016 to 2017. Fast forward to 2020, and we have had 10 cases in half the time. Very worrying. I further looked at our records for diagnosis of ordinary scabies presenting to our clinic. These numbers are red flags to me. They represent the tip of the iceberg, so lots more scabies out there. The more scabies there is, the greater the possibility of someone developing crusted scabies. And of course, the more crusted scabies you have, the more likely to have more cases of scabies. Conversely, if there is no scabies, there will be no crusted scabies, which should be our goal. With the advent of COVID, the concept of the super spreader has re-emerged. Patients with crusted scabies are highly contagious and are certainly potential super spreaders, as they can serve as a source of outbreaks in populations, institutions, healthcare workers. So we've seen this happen. But what's the big deal? Are 10 cases really that many? So this is a review of the international literature from Australia and Senegal that have reported large series. And as you can see highlighted, cases average 6 to 11 per year. To put that into perspective, if you compare the populations, the respective populations of these countries to Jamaica, 10 cases is quite alarming for Jamaica. And this is just our clinic. We haven't collated figures from UWI or Cornwall Regional, and I'm sure they have, so this is most alarming. Looking at Jamaican data, 40 years ago, Dr. Lagranade published a series of 12 cases presenting to the University Hospital. So very little has changed. Of interest, she describes 7 cases with comorbidities that might cause us today to check the HTLV1 status of these patients. It would be another decade before her seminal work in HTLV1 and infective dermatitis, while simultaneously Prof. Morgan et al. Researched HTLV1 associated polymyositis, and Prof. Hanshud studied HTLV1 associated adult T-cell leukemia. We remain indebted to these trailblazers for their scholarship. So then, is this the missing link? Jamaica has a high seroprevalence of HTLV1, and the association of crusted scabies with retroviral infection is well described. At this time, the HTLV1 status of my cases is unknown. We're still waiting on results. But I would, however, like to take this opportunity to urge all those who provide antenatal care to include HTLV1 screening as part of the workup in order to reduce mother-to-child transmission and reduce our seroprevalence perhaps in another decade or two. So on to the pictures. So this young lady has SLE and is on prednisone. That's 2 reasons for being immunocompromised. So if you have a steroid-responsive dermatosis and it's no longer going well, you have to think of alternatives, and crusted scabies is one such alternative. Note that she was given RID. So someone would have given her RID for a day or two and the rash would not have improved. Why? Because it's crusted scabies and needs to be treated for a lot longer. So crusted scabies doesn't look like this. The gentleman on my left, your right, overnight, but starts insidiously. And so you still see the papules in the web spaces, but note now that it's getting a little crusted, a little scaly. And worsening case, different patient. But note still the web spaces crusting around the umbilicus, so look for the clues. But he is improving on treatment, albeit slowly. This young man with no apparent comorbidity was prescribed potent topical steroids for itching and developed this crusted plaque. Now, there's just something wrong about this. It's not eczema. It's not psoriasis. It just looks strange. So you want to ask yourself, could it be something else? So steroids and scabies don't go together. You will get crusted scabies, especially if you use potent topical steroids. And this is him again. This patient has remained a challenge to me because he has not been able to tolerate the antiscabetic treatment for long enough to actually clear him due to the irritation. Permethrin is the less irritant of the available antiscabetics, but still he was not able to tolerate it, and so we continue to search for a solution for him. This patient presented with these concretions, over the bony prominences, web spaces, still the umbilicus, wrist, and these crusted plaques looking like you could just break them off. Still the web spaces. So the clues remain for a long time. Look for them. There you go. So yes, it can get quite bizarre, and but if you stick to principles and look for the clues and bear it in mind, ask yourself, what if, and perhaps you will arrive at the diagnosis. This elderly lady who actually demised, as you can see, very cachectic. But I put her here to again show you, look for the clues. There are complications associated with crusted scabies, depending on the severity and the duration. Be reminded that the skin is the largest organ of the body and is integral in homeostasis. You damage the skin barrier function and there are consequences. Patients can have weight loss due to altered metabolism, nutrient loss since all that crust and scale is protein. Patients become anorexic, all a part of the catabolic state. Anemia and hypoalbuminemia further impair the immunity. And there are a host of other complications. And there is actually a mortality associated with all of this. So the management of crusted scabies may be quite challenging. Longer courses of antiscabetics are needed until clearance is achieved. Since we just have half of the treatment of choice, we have to soldier on until patients are clear. Patients will need to be investigated and managed for any possible cause of immunosuppression. And of course, they need nutritional support and other support, treat infections, etc. Whatever the management that is required. And again, always treat all contacts. And what of permethrin resistance? According to this article, mites treated with permethrin have been surviving longer from 20 years ago. My own feeling is that it is taking longer to clear patients, hence my concern about a shortened application time that is being proposed recently. So I have a few recommendations. I would like to see tax be removed from the antiscabetics or possibly the cost subsidized. We need updated prevalence studies of scabies and crusted scabies in Jamaica. Physicians need to remind themselves from time to time of scabies and its management. I suggest that we err on the side of caution and treat a bit longer for ordinary scabies. Consideration should be given to making crusted scabies a notifiable disease. This is what the Australians have done with good reason, and our figures are higher than theirs. I would like to lobby for ivermectin to be added to the formulary to treat crusted scabies. It's about time. It's 50 years old. It's time for us to have it. As well as for the placement of dedicated dermatologists in all of our regional health authorities. A public awareness campaign would be quite useful, and perhaps here we could partner with the Department of Neglected Tropical Diseases from PAHO, who would be more than willing to help us according to their website. So, in conclusion, there is a high incidence of crusted scabies in Jamaica, and I suspect a high incidence of scabies generally. There's a prolonged delay in referral, partly due to poor recognition. Treatment at this time is limited to topical treatment, and although we achieve success, it takes us that much longer, and in that time, consider the possible spread. There needs to be an increased awareness of both scabies and crusted scabies. And most importantly, we need to identify and treat scabies adequately and promptly to avoid development of crusted scabies in susceptible patients, because immunocompromised patients are not inherently more susceptible to scabies. They still have to be exposed and get the scabies. If they are exposed and treated, they will clear. They will not get crusted scabies. All right. So it is really quite critical that we catch this, and this is especially important in the primary care. I thought I would end with some prettier pictures. Thank you.
To a mite, right? We do see on occasion crusted scabies, and as Dr. McLeod has said, sometimes it's a diagnostic dilemma. So once we are aware and we have our suspicions, then we should refer to the specialist for care and have a heightened reluctance to use topical steroids on things we do not appreciate or understand. I think that's a take home from this message. Right now, we'd like to have our gold sponsor, AA Lackeys, who will be presenting to us. Our history with AA Lackeys goes back a very long way to our very first conference in which they were our gold sponsor, our primary sponsor. And they continue to support the KPH conference and to support the health services of Jamaica. So I'm going to ask Ms. Marianne Serrano to present for AA Lackeys, our first gold sponsor presentation.
Presenter mode.
Perfect. Thank you. So, afternoon, everyone. Thank you for the spot. My name is Marion Serrano. I'm the Johnson & Johnson Ethicon professional sales rep for Panama and the Caribbean. Sorry about that. I had the YouTube link also on, and I was hitting myself double. So that said, I'll be presenting for AA Lackeys today. We'll do a brief summary. Okay, thank you. So as I was saying, we have a portfolio that is divided in two families. We have the cellulose oxidized regenerated portfolio, and then we have the gelatin portfolio. And we're going to go over it real quick. So to start off, let's go and talk about our cellulose oxidized regenerated portfolio, which is our Surgicel family. Okay, so our Surgicel family comes from this vegetable origin. Okay, it's kind of a cloth type. We consider it that is bactericide because it works in low pH, and it will reabsorb between 7 to 14 days. Now, this part is very, very important because we know that during the procedures, we want to leave as less product as possible in the patient and only as needed. So this product will absorb. And the good thing about the Surgicel is that the fact that it's being regenerated, it will allow them to absorb evenly or equivalently. And if you look at the studies of Surgicel, it will the clinical evidence will show that it does so. Surgicel Original has been in the world for more than 50 years, and this is currently available in Jamaica through the NHF tender support. Now, Surgicel works in our hemostat cascade in two areas. It works in our vasoconstriction, okay, and then it was also in the plated plug area. Now, I would like to discuss a little bit about the family that we have in Surgicel. We have expanded our portfolio. You know, technology is always growing, always moving forward. And we have included 3 new Surgicels to our Surgicel family. Now, the first one is the new need. Okay, so the new need, it's kind of like, it's still a cloth, but it's a little bit more thick. It might look like a type of mesh, but it's still soft. Okay, so this type of hemostat might be used in the procedures where there's a lot of trauma. For example, where we have like liver resections could be an example. It could be sutured to the organ, or wrap around the organ and leave it in there, since it will absorb. Compared to our Surgicel Original, this works 36% faster than the Surgicel Original. Then next we have what it is, the Surgicel Fibular, which it looks a little bit different, changing the cloth type. It kind of looks like a sponge. And the fun fact about it is that you will be able to separate it by layers. It will allow you to have about 7 to 8 layers. Now, the good part of this is that it could be used in many type of procedures. It could be used in cardiovascular, it could be used in spine, neurosurgery. I have also seen it, for example, in head and neck, since it's a very small area. So some doctors will separate the layers and just place it in it to reduce any risk of post-operative bleeding when they do in head and neck procedures. This type of hemostat works 33% faster than the Surgicel Original. Then we have the Surgicel Snow, which is kind of similar to the Fibular. The only difference is that this one will not allow you to move it by layers. It's just like a more compact, maybe, cloth. And the good part of it is you can use it also for open and laparoscopic surgeries, but it's mainly designed for laparoscopic surgeries, because if you try to introduce probably the Fibular family, once it goes through the trocar, it might like leave some of the product behind. The good thing about the Surgicel Snow is that you will be able to like wrap it around, put it through the trocar, and it will go and be placed very easily where you have to do so. And it also allows reposition during the procedure. So if you see another bleeding, you can actually like take it and replace it where you actually might need it. As per if you use the Fibular, you might not be able to do so. So each of them has a particular area to be used. So as a review, what we can say out of each one is that the Surgicel Original is known for its flexibility, the new need for its force, the Fibular for its versatility, and the Snow for its adaptability. Now, that's it regarding the Surgicel family. We're going to go and discuss about a little bit of our absorbable hemostats, but the gelatin family. And in here we have the Spongostan, or you might also have heard of it as a Surgifon. Okay, so it's the other name that you might hear from Johnson & Johnson States. Its origin is from the porcine gelatin, from its collagen, and it will take a little bit longer to absorb compared to our Surgicel family. Okay, it will take about 4 to 6 weeks to absorb. Bear in mind that it does increase about 20% of its size. So if you have port instructions on site where you are placing it, we recommend to cut the product. It will allow you to do so, and then place it where you need the hemostat to be done. Its mechanism of action is in the plated plug. Just bear in mind that these products do not skip any step of our natural hemostat cascade. What it will do is it will make our process faster than what it will normally do. This also comes in like not only the size of like sponge, but it also comes like in a round version. I have seen it, for example, in other countries use it, for example, in hemorrhoidectomies procedures. They'll just put it after the surgery. We also have a powder version of it. continuing with our advanced hemostatics, we also have the advanced fluid gelatin, which is called for us Surgiflow. It also comes for the porcine origin. It will take about 4 to 6 weeks as well to absorb. It will increase its 20% of its size. So if we have exceeded product, please remove as much as you consider needed. But the fun part and the very important part of Surgiflow is that it allows you to have very good access in those cavities that usually is kind of like very hard to use. It has its particular procedures to be used, but overall we'll see some examples ahead about any type of procedure that could be used. Then again, from our hemostatic cascade, this works also with the plated plug level. Now, here's some of the general characteristic, and this is an example of what I was telling you, that it will allow you to place the hemostat exactly where you need it. It will stop the bleeding between 2 minutes. It's very easy to prepare, just 30 seconds. It has 2 applicators, one that you can bend, the other one you can cut. At the end, it will give you, with a mix of the product and the saline solution, about 8 millimeters of product. It doesn't need a needle for the preparation. Everything comes in the kit for once you need it to prepare. You just need it to open, and the scrub tech will do the preparation right away. And the fun part, and I think it's kind of like easiest, is that it doesn't require refrigerator. Some of the hemostats do require this, and makes the change, logistic change, including in the hospitals, the inventories and stuff, a little bit difficult, and it will make the process harder. So it does not require refrigerator. So now we'll go and see some examples of where it could be used. In neurosurgery, it could be used, for example, and I apologize for some of the words in Spanish. These are pictures and I could not modify them, but it could be used in craniotomies, in tumor resections. As I show you here, probably if you see a little bit more of the product, you may remove the excess, so the exceeded part, so it will, remember, it will increase 20%, and we don't want it to be doing pressure to any other important areas. It could also be used in spine. It could be used in cardiovascular procedures, as we can see in examples here. In general surgeries like cholecystectomies, rectal resections, hepatectomies, resections. To be fair and honest, I know this probably is a high product to use in a colon, which is not as an expensive procedure, but it's showing us that it also has versatility, that it could be used here, same as a Surgicel original. Some doctors will prefer, and I've seen it more, like for example in neurosurgery procedures, in cardiovasculars. We also see examples here in urology for the prostatectomies and the partial nephrectomies, and in gynecology as well for the hysterectomies and the myomectomies, especially the laparoscopic procedures. It comes with a laparoscopic adapter. It's a side, but it also has one. So then, to close up and wrap up this moment, I wanted to leave out the last review of our portfolio. This is our whole hemostatic cascade, where we have our Surgicel family working in the vasoconstriction and plated plug formation. Remember that we have all these 2 new products in the market as well, available for you guys. And then we have our gelatin family, which is the Spongostat or Surgiphone, and our Surgiflow, which is the fluid gelatin hemostat, which both works in the plated plug formation. That said, guys, I wanted to thank you for the spot. And if you have any other questions regarding our portfolio, bear in mind that we distribute this through our local distributors, AA Lakis Limited, and you can contact Shireen Campbell for any further information. Thank you.
There would be no surgery almost. So thank you very much.
That's so true. Thank you.
All right, you're welcome. Thank you again for your support over the years. If you would like to leave comments or questions, and we'd like to take them now, you could simply refresh the YouTube page, and then you'll be able to make your comments, and we'll record those comments and ask our presenters to respond. I'll respond on their behalf. All right. While you refresh the page and we await our next next sponsor presentation, which will be from the National Health Fund, we'd like to go through our list of sponsors again and thank them for their support. So we'll start off with, yes, A.A. Lakis, who has been with us for 13 years, 13 of our years. Also, Boringa Ingelheim, who has contributed so much to the KPH over the years, always willing to support our conferences and provide us with equipment when asked. Then we have the National Health Fund, our major sponsor, our platinum sponsor, and they've been with us for a number of years now. I want to thank them again. Also, Facey Commodities, About Nutrition, the Caribbean School of Medical Sciences, PA Benjamin, Apex, Imaging Associates, and Alpha Med Global. Right now, we're going to invite Ms. Charmaine Robotham from the National Health Fund to do her presentation. Yes, we are.
Hello.
Go ahead, Ms. Robotham. We are hearing you.
You're hearing me? Okay, wonderful. Good morning, everyone. Let me say what a pleasure it is to be presenting at the KPH conference and to congratulate you for putting on this conference. I know you've been having a lot of challenges this morning. So we are happy that we're forging ahead. Now for today, I'd like to talk to you about the NHF card. And in that, I want to look at the merger of the JADEP card with the NHF card, the new application form, special arrangements for COVID, online registration for doctors, and close off with the drug serve alternate services. How do I advance? Okay, now, as you know, NHF covers 17 conditions, and the latest one was lupus. There are some persons who are still unaware that NHF is now covering this condition, so I just wanted to bring that to your attention. Now, effective September 28, all the great benefits of JADEP are now on the NHF card. So for persons who are 60 and over, who have both the NHF card and the JADEP card, they now only need to use the NHF card. For individuals who only have the JADEP card, and we have quite a number of these individuals, we are asking that they upgrade to the NHF card, because that will allow them to have the benefits of the NHF card, and they wouldn't have to walk around with both the JADEP card and the NHF card. So if you are aware that any of your patients only have the JADEP card, please encourage them to get the NHF card. We now have a new application form. Formerly, as you know, we had the yellow form, the blue form, the pink form. We have amalgamated all of them into one application form. So whether you are applying as an over 60 or under 60, this is the application form that you will use. The areas are basically the same, of course, the applicant, the guardian, if it's in the case of a child, and of course, Section C for the physician to complete. So whether you have lost your card and you're replacing your card, whether you want to change your name or whether you want to add a new condition, we will use this new form. Now, what you may ask, will we be doing with the other forms that are in the field? We will continue to use these forms until they are complete. Whether you use the yellow form or the blue form, which was formerly the change form, it really doesn't matter at this point in time, as long as you're able to write in your TRN. For the JADEP form that is out there, we are no longer enrolling persons with JADEP who do not have a TRN. So those forms are not really going to be used at this time, because we also want to indicate the specific conditions that the candidate has. And on the JADEP form, not all the conditions are clearly identified as they are on the NHF application form. So we'll continue to use the blue change form, the yellow form, and of course, the new form. Now, in responding to COVID, NHF made a number of changes. We promoted the filling of prescriptions for up to 90 days. And in addition, we also changed the number of days that you can come in to fill your prescription. So normally, before this, you would fill your prescription for 30 days and you would be able to come in 6 days before the end of that 30-day period. What we have done now to ensure it is convenient is you can come in on day 15 to refill your prescription. If you got a prescription for 60 days, then you can come in on day 45. And if you had filled it for 90 days, you can come in at day 75. So that we're trying to make it easier for our clients so that they don't have to come to the pharmacy, hear that, oh, it's not time as yet, and then they have to come back another day. And that way we are reducing their exposure. Okay, why isn't my thing advancing? The other, oh wow, what's happening here? The other thing I would like to talk to you about is the online registration for doctors. Starting December, we will be introducing an online platform for registration for patients for the NHF card done by the doctors. So doctors will be able to fill in online their usual information as well as the patient's TRN number and submit that to us. So there'll be no need to actually have NHF forms in the office. If you're going to be using technology, you will never run out of NHF forms because it's now online. And it's also an easy sign up for patients, because we have heard so often of patients who have had the form signed off by their doctor, but they are keeping the form at home and not taking it into us. So in this way, we will have the patients easily getting their application for NHF card into us, and then they come in, sign one, pick up, and get their NHF card. We are seeking to have some 30 doctors starting on the new system. If my thing would advance, we're seeking to have 30 doctors pilot the program. So if you are interested and would like to be a part of the pilot, please give me a call, 832-8675, or give me a call at NHF 906-1106, and we will have a conversation and to get you on. also, before we close, would also like to bring to your attention, I'm trying to advance my slide, and for some reason it's not going forward. Just want to talk to you about the drug serve alternate services. We have been trying to push the alternate services for our public patients to use the scheduled refill, because for those patients who have chronic illnesses, we know that they're going to be getting their prescription every month, so we schedule them on a particular day to come in and collect their medication. We are encouraging more and more of our patients to do that. We also have the drop-off and pickup, and in response to COVID, we have introduced the home delivery. And what this means is that for persons who are 65 and over, we offer them home delivery. So we actually deliver their medication to them at home, so that they do not have to come out and face the crowds at the pharmacy. And in this way, we are seeking to protect them from COVID-19. So I just want to say thanks again for KPH allowing us to come on and to share with you in relation to NHF and all of our services. And if there are any questions at this time, I would be happy to take them. Mm-hmm. You're welcome.
I'm out of jail. And I will be passing the baton on to Dr. Renee Badru, our hardworking chairwoman of the 2013 KPH Conference Committee. She has worked very hard behind the scenes, and now she'll be in front of the camera as she moderates what we will call session 2. So without much ado, I'll hand over to Dr. Badru at this time.
Hi, good afternoon, everyone, and just want to say a big thank you for everyone that has logged into our conference. We really had some technical difficulties, but we just want to thank you for staying the road and being here still with us. So we move now to the second half of our conference, where we have our keynote guest speaker. And our keynote guest speaker today is Dr. Alfredo Walker. Dr. Walker is a medical graduate of the School of Medicine, Faculty of Medical Sciences, University of West Indies, the St. Augustine campus. He attained his degree in MBBS, and he belongs to the class of 1996. Currently, he's a registered forensic pathologist, category A, at the Ontario Forensic Pathology Service, which is based in Eastern Ontario. Eastern Ontario Forensic Pathology Unit at the Ottawa Hospital, the General Campus. He holds an academic appointment of Assistant Professor in the Department of Pathology and Laboratory Medicine of the Faculty of Medicine, University of Ottawa. And he's also the Vice Chair of the department as well. He's a lead trainer in forensic pathology in the department's residency in anatomical pathology program and has won 2 University of Ottawa Teaching Awards in 2014 and 2017. Continuing, Dr. Walker pursued a postgraduate training in both histopathology, anatomical pathology, and subspecialty training in forensic pathology in the United Kingdom. His postgraduate training in forensic pathology was funded by the British Home Office, after which he has won seven forensic pathology awards, and he has also had an appointment in the National Recruitment Exercise that was done in 2003. Dr. Walker also attained the Fellowship of the Royal College of Pathologists of the United Kingdom, and he also attained a diploma in medical jurisprudence by examination. Internationally, he has performed forensic postmortem examinations, and he has also provided expert opinions for agencies in many jurisdictions such as United Kingdom, the Republic of Georgia, Germany, Anguilla, St. Lucia, Trinidad and Tobago, and the many Canadian provinces and territories. He acts as a resource person for pathologists who perform medical legal postmortem examinations in Belize, St. Lucia, St. Vincent, and the Grenadines, Trinidad and Tobago, and he also provides support and expert advice. Dr. Walker has been invited as a guest speaker for many international and regional conferences, and it is indeed our honor to have him here to present. So please, wherever you are, just give a round of applause for Dr. Walker.
Right. Good day, everyone. Thank you very much, Dr. Badru, for that introduction. Can you see me? Can you see me?
No,
Can you hear me?
we can hear you quite well, but we're not seeing you.
My video is on.
Can you share your screen with us, please?
Yeah, I'm trying. Just hold on a second.
Where's the screen? Okay, we're seeing you, Dr. Walker, but your presentation, however.
Yeah. I'm not getting the option to share screen. Hello?
Hi, Dr. Walker. Yes, we're waiting on it to share.
No, I'm not getting the option to share my screen.
All right, there's an option that says screen at the bottom. Can you click that option?
Yeah,
and
it's
then
not opening.
Okay, give me 1 second. Is he a presenter?
I'm on a Mac.
You're on
So
Mac. He's on a Mac.
Oh, yeah, but it's still not allowing me to share screen. I think it has to do, um, I need to, let's go to meetings. So let's activate the permission. No, it has to be clicked. I think you should go on with the other speaker. It has to do something with the permission to for me to share the screen on this Mac. I'll have to sort it out. I've never had this issue before. Okay?
Okay, in the meantime, as we are loading Samantha Nicholson Spence presentation, we just want to have a shout out to our sponsors. Now, this year's conference would not have been possible without our sponsors, which are National Health Fund as our platinum sponsor, AA Lacui as our gold sponsor, Boringo Ingraham, the Facey Commodities Group, About Nutrition, Caribbean School of Medical Sciences, and PA Benjamin as our gold sponsors. Our bronze sponsors include Imaging Intervention Associates, as well as Alpha Med Global and Apex Radiology. As we continue, Dr. Samantha Nicholson Spence is a dedicated Christian, wife, and mother of two. She is a proud graduate of Campion College, and she embarked her undergraduate medical training in 2002 at the University of the West Indies, Mona campus. She sailed through medical school as on the dean's list, and she earned her MBBS as well as her BB MedSci with honors in 2005. She also received honors in her surgery rotations as well. She completed internship and senior host office positions at the Kingston Public Hospital, and it has afforded her the greatest patient load and pathological diversity, and by extension, unmatched clinical experience with greater potential for philanthropy. Dr. Nicholson Spence was accepted by the University of Miami Miller School of Medicine Regional Campus to pursue postgraduate training in internal medicine in June 2009. In 2012, Dr. Samantha Nicholson Spence graduated with her Doctor of Medicine in Internal Medicine and subsequently sat the American Board of Internal Medicine examination, where she would score on the 10th decile. This was the highest one amongst all candidates that year. She ascended to the rank of Fellow in the American College of Physicians in 2015. She returned to KPH in 2012 and now she serves as a consultant in the Department of Medicine, an associate lecturer in the Department of Medicine, and she's also the head of the Department of Medicine. She was elected head of the Department of Medicine, as I said previously, in 2019, and now she continues to do an excellent job, especially with regards to the COVID-19 pandemic that is happening globally. So, ladies and gentlemen, please help me to welcome Dr. Samantha Nicholson-Spence.
Good afternoon. COVID-19 has upended our lives, and at KPH it has been no different. The timeline, it seems like it's been forever that COVID has been here. However, it was in December 31st to be exact, last year, when the first case reports of a cluster of viral pneumonia was first reported in Wuhan, China. By February 11, the disease was named COVID-19. March 10, Jamaica recorded its first case of COVID-19, which was an imported case. And on March 11, the World Health Organization declared COVID-19 a pandemic. On March 16, KPH admitted our first case of COVID-19. And even leading up to that point, we have had several meetings and sensitization sessions. The Department of Medicine has been working assiduously as we try to prepare for the pandemic and weather the pandemic. We are a team not just of physicians, but we have an excellent infection control team. These superwomen here have a combined over 54 years of service to KPH and have been at the forefront of managing this pandemic. We are aided by our infectious diseases consultant, Dr. Audine Garrison, who has been working tirelessly as we attempt to weather this pandemic. And not the team itself. We have Sister Stewart, who first served as the ward manager, the nurse manager for the COVID ward when we first opened in March. We have several PCAs of note, PCA Bailey, and not to mention our nurse educator who has been very instrumental in getting everyone trained in proper donning and doffing of PPE. This is a current team now, the charge nurse on the COVID ward. Please note Sister Fowles there, and several other nurses, too many names to call, who now form part of the team. There are several residents who are part of the team. Several have actually volunteered to go back and do COVID duty and have served exceptionally in this process. And not to forget our ancillary staff. Our porter, Mr. Singh Seen here, has been working with us from the start and has been serving us very well. When he's not on, it's not good. And of course, who can forget our big boss, Dr. Natalie Wiley. Now, the COVID-19 experience at KPH. So, between March to October 31 is where I did data collection, and during that period of time we had 708 patients isolated, of which 217 tested positive for COVID-19. There are several with unknown results, and this was for various reasons. Either the results did not come back or patients were not swabbed and it was not noted before. And there are some patients who unfortunately demised before they were swabbed. And when we look at the trend over the period from March to October, you can clearly see that there are two waves or two spikes. So in March, when it was first recognized, and then April, we have a peak, and then the numbers sort of went down. This was a period of complacency for the country as a whole. And then by August, September, we see the cases spiking again in what is known as our second wave. Now, the yellow line is showing mortality. So between March and June, there were no mortalities. There were no cases of mortality. However, by the time we get to August and September, we see a rise in mortality. And this corresponds to what we note in this second wave, that the patients are overwhelmingly more severely ill. Of note, as we got back into October, the numbers started to go down again. Again, this is not the time for complacency, as we must prepare for a possible third wave. So, with that being said, in preparation, we wanted to evaluate what was happening at KPH, and so a retrospective analysis was done of our patients. We want to see, when we use our local data, is it matching up with what is seen internationally with COVID-19? Is it different here? Is it the same? And can we do better prognostication and potentially have timelier interventions? So, the method, we reviewed 710 patients for inclusion from March to October 2020. Selected the patients from the second wave because there were no mortalities in the first wave. And so the second wave began around August 15. And so we reviewed dockets from August 15 to 31st. During that time, there were 58 deaths recorded. And so we requested dockets for all 58. Only 56 were localized at the time of the study. And we reviewed 54 matched survivors. Now, they were matched only based on the time that they presented. So they were not matched based on age, etc. It was whether or not they came during the second wave. And then we compared both groups for age, comorbidity, vital signs, laboratory findings, and any other features that are associated with negative outcomes. And the result was, as it relates to female versus male deaths versus survival, it was roughly the same. There was a clear difference though in age. Older patients were more likely to die. And this has been echoing what has been said over and over, that age is the most important risk factor. The presence of a comorbidity as well, statistically significant, noted that death was more likely if a comorbidity was present. And the comorbidity that we noted that was most associated with dying from COVID was actually hypertension. Diabetes was present in several of the survivors as well as those who died. However, hypertension was far more significant. Diabetes only became significant when you lumped the patients who had both diabetes and hypertension, but diabetes by itself did not appear to have an impact on survival. Interestingly, HIV, though there were few cases of positive patients who were in fact COVID positive, HIV positive patients who were in fact COVID positive, this also was not statistically significant. Now, this may be because the HIV patients are turning at them yard and are not getting infected, but we did note that there was no significant difference. Chronic kidney disease, there were quite a few patients who were isolated to the SARI ward. However, these patients, many of them turned out to be negative. And when we looked at the deaths versus survivors, again, that was not statistically significant. When we looked to see, is it a case where the patients are presenting later, and so by the time they have arrived, we're no longer able to save them? Well, in fact, when we looked, there was no statistically significant difference between the time to presentation, i.e. the sick days. It was 4 versus 4.7. So it's not that the patients who died were waiting later to present. What was significant was the length of stay, which would make sense. So those who survived stayed very long. In some cases, patients stayed as long as 6 weeks. It's not uncommon for COVID-19 patients to remain hypoxic for a month. High flow nasal oxygen was utilized in several patients, and for those that were studied in this particular trial, we noted that there was no difference between the survivors and the deaths, but that is because the numbers were small. The issue with high flow nasal oxygen is the need for a space to safely administer it without causing aerosolization and worsening nosocomial transmission. When we looked at the laboratory findings, and I looked at several, the ones that were significant was white blood cell counts. Now, we're often told that COVID-19 is associated with normal white cell counts and leukopenia. That was not the case for our patients. In fact, most of them presented what would look like a bacterial sepsis kind of picture. They had leukocytosis and predominantly a neutrophilia. And it was more likely, the white cell count tended to be higher in the patients who eventually succumbed to the illness. BUN was elevated more so in patients who succumbed to COVID-19 than in the survivors. And this too is a marker of hypoxia, because with worsening hypoxia, there's worsening perfusion to the kidneys. A ion gap was evaluated in patients. It was statistically significant as well, and we believe also related to hypoxia. When we looked at the vital signs, the presentation of COVID-19 often is with SEERS. So patients present with very high temperatures, as high as 105 was noted in one patient, and that patient did survive. And heart rates 140, 150 are almost routine. Tachypnea is seen, low oxygen saturations, and hypotension is a frequent occurrence. So these patients actually present with sepsis, looking just like a bacterial illness. And when we looked at death versus survivors, though the temperatures went as high, it did not have any prognostic significance. What did was the level of respiratory distress, respiratory rates, and oxygen saturation. So hypoxia overwhelmingly seems to be the most important factor here that is separating the survivors from the deaths. But that being said, though, we had patients presenting with hypoxia, oxygen saturations as low as 40%, 50%, who still survived. Level of glycemia as well on presentation did not have any significance, whether a patient would survive or die, which goes back again to the diabetes, which did not appear to be statistically significant. So from review of the data, it can be seen that the predictors of mortality, at least for our patients here at KPH, have been age, the presence of a comorbidity, and particularly if that comorbidity is hypertension. The presence of tachypnea and hypoxia on presentation, leukocytosis, and elevated BUN are all predictors of mortality. And the next step, or the next logical step from here, is to see how we can combine these values and come up with our own scoring system or prognostic calculator so we can better or aggressively manage our patients. Earlier recognition of severe disease and better triaging can come out from utilizing the data so that we now know what factors portend a worse prognosis. And especially with the rapid test, which has been made available to us, this will be even easier as persons will be recognized faster. The results also underscore the importance of ABCs. From medical school, we've always been trained, ABCs, airways, breathing, circulation. Well, airway breathing particularly seem to be the most important issue here in our COVID-19 patients. It's hypoxia that has been overwhelmingly the worst prognostic factor. And in fact, when we look at the manner of death, it is due to respiratory failure, which is hypoxic respiratory failure. We don't see hypercarbia much in COVID-19. So is there a role for earlier use of dexamethasone or broadening the spectrum? That's something to consider, or to review the literature to see if hypoxia is the only means by which we say someone has severe disease. And earlier use of remdesivir, or making remdesivir available so we can reduce the number of patients who progress to severe disease and eventual death. I want to also point out that while there was a clear demarcation between survivors and those who died, by no means were the survivors mild disease. Mild disease was not admitted to KPH. particularly while we were experiencing the second phase, which is what this data is capturing. September, August, we were admitting patients with severe disease. There are few patients with moderate disease admitted, but most patients were severe. So even though they presented with severe disease on presentation, they still survived. And it's very important to note that. And so that's why we need to know what is it about these severe patients, why this severe patient with an oxygen saturation of 40 makes it, but this one with a 45 doesn't. And this is where I'm going to end it there. Room for question as to how we can improve our outcomes in COVID-19 as we get ready to battle the third phase. And I would just like to acknowledge persons who helped me to gather this data, because it was not easy to go through 700 and plus records. I want to thank nursing office, particularly Matron Joan Walker Nicholson, Deputy Matron Mackenzie Cooks, and Mr. Bent in the office, because we had to go through literally hundreds of papers. I also want to acknowledge the medical records department, because to locate so many dockets was not an easy task. I would also like to acknowledge Firm Best, because I have a great internal medicine team working with. I was able to devote a little more time to gathering the data for this presentation. Thank you.
Okay, thank you, Dr. Nicholson Smith. That was an excellent presentation, and I really must commend the COVID-19 team. They have been doing an excellent job, and it has been tremendously stressful for them. And we just want to commend them and thank you, thank you, thank you. Now we move on to our next sponsor, which will be Facey Commodities, and our speaker today will be Mr. Wayne Manning. So I just ask for you to give us a couple minutes as he gets his presentation up. We just want to also acknowledge the rest of our sponsors, which are National Health Fund, Abbott Nutrition, AA Lacley, Facey Commodities, as well as PA Benjamin, Beringa Ingraham, and Apex Radiology, Alpha Medical Global, and Imaging Associates. Thank you. Mr. Manning, we're not hearing you. Do you have your mic on? We're not hearing you, sir. We're seeing your presentation, but we're not hearing you.
Are you hearing me now?
Yes, you are, but you are a bit fuzzy. We are hearing you, but a little bit fuzzy. Can you turn down the speaker in the background?
Are you hearing me now?
We can hear you.
Okay, thanks. All right. We will come to KPH this opportunity to talk about whatever we put in our mind forward. And let's start by looking on the conversation of compliance standards and performance and practice with respect to particular matters. And what we're going to do now is demonstrate that standard drugs will contain particular matter. The important thing is to reduce the amount of particular matter that are in particular drugs. We know that there are sizes of particular matter that may be in particular drugs and can be associated with harm and also the potential for reducing efficacy of the product, in this case antibiotic. So the possible adverse effects of particular drugs from a bacterial contamination perspective, of course, sepsis, bacteremia, death, and so on. With respect to particulates matter contamination, we see the potential for antibiotics, granulomas, so the timeline of particulate matter and the impact that it can have on intravenous administration of drugs to patients. As you can see, now this is how the blood bacteria receiving attitude will be of granulomas. And the first approach is put on here, you can really balance, and that is the cure of that and God impact the solutions and impact the animal lungs. 70% catastrophic material contamination of attitudes with the sepsis and death. In 1985, the United States Pharmacopoeia began with 78 dates and became the first official particle matter standard in both small volume and large volume biographs. 1995, was made an amendment to that original USC 78 dates and lowers what is acceptable material particulate matter from standard for both small and large volume. I'm trying to get my slide for this. Okay. I just have two devices on at the same time. Hello? Right, this
Mr. Manuel?
Yes?
I believe you have two mics on or something on at the same time because you're getting a lot of feedback from us.
My device is it's the only device that I have right now that is open.
Can you turn off the speakers or something?
If I use the headphone, you're probably not hearing me. Let me see if I use the headphone.
Alright, can you just turn off your computer speaker till you finish presenting?
As it is, it's just my computer is open, the video and the audio is open. Will it still get feedback?
It's not as good as before.
Okay, so may I continue?
Yes, you may continue.
Okay. Previous slide also. Right, that elements on what is the current combination in terms of number of particles per container and the particle size. And against a small volume greater than 10 micrometer, it comes to. And for those that are greater than up to 25 micrometer, it comes to that is recommended from the 1995 USC found up here. With a large volume, it gets greater than 10 micrometer, greater than 25 micrometer, which is recommended per minute. And this approach shows the new distribution of particles here solid guidance in sizes from 5 micrometer up to 50 micrometer range. So you can see from various solutions, from 5 micrometer large quantities that happen. The larger the particles, the less of the particles in the solutions. When we go with this, we can see that in a number of cells, organic cells, for example, along here, in a large size of 3.4 micrometer, there's a high percentage of particles in the lung. The large part is 7.4, there's a high percentage in the lung as well. And the larger part, you can see also 93 there. There's large amounts in the liver. So we can damage the result of active matter in your parental drugs. So we see pathophysiology, mechanism of time, mechanical blockage of small fiber hydrogen. The population increase after the food and the food addresses after local parental drugs. And in practice, low level of population would make the popular matter remains inevitable. The generation of pattern matter is controlled by a number of molecules and techniques in the manufacturing of the particle drugs. Parts of the history to the body based on their size and the potential of involvement by macrophages. Now, the same story. There is not an antibiotic at the moment for quite a while, and it's food very efficacious and safe. However, there were situations where there were increased incidences of high pathogen matter, and this is where the reformulation association comes in. And there is a routine surveillance at wide because the company manufacturing product indicating further occurrence of excessive levels of subunit particles. So they decided to analyze what was actually causing that. And of course, made adjustment to meet the code USP 78 standards. Just saying on the molecule of potassium is about the sourcing. We know it has to be acting there is mixed macroside activity. At low pH, this can be actually converted to potassium acid, which is insoluble. And then with the high presence of metal ions, this potassium acid will dimerize. Because the number of ions can catalyze the reaction, push the reaction forward. So you form a dimer which is able to insoluble. So there are simple things out here. We're causing increases in the amount of particles in the drug. At the same time, we are the potassium or beta actin, which is efficacy. So I said, with pH and chemical ions, the barriers that will use to reactivate the product can actually influence past performance and reduce the available beta actin in its activity of treating the infection. And also to expand the ranges of pH in various barriers. So you can see it's more listed as too much acidic, 2.5 to 6, in some cases up to 7, so it's super acidic. And these are common barriers that are utilized in making the solution of the antibiotic. This also, this slide shows variation in the same levels of various variables. In this case, on the left, we have sodium chloride, and these are different matches of the sodium chloride. And you can see various levels of zinc. And it was quite certain which of these matches we are getting, and therefore we know exactly what zinc content we do have. And same thing with this side here. So you can see the level of zinc in this as well. Very. Now, the potential consequences of variability in nuclear ions. One, undesirable level of degradation of the product. So in this case, the particles will take the market and unstable. And as a result, it form excessive number of particles, which can cause a lump oxide. So whilst reforming the compound by adding storage situated at buffer to control the pH, and then it adds EDTA, which will accumulate and tend to remove excessive transition and testosterone zinc. And that typically stabilizes the molecule. Now, this actually shows the glycolytic stream rescue recommendation in the of number of particles at the very top. And this is for small volume injection. And then here it presents at 6,000, CFC 1995 for the third being revised. Finally, reiteration is after reformulation, it is not seen by the lower less than 1,000 particles. So we are seeing the improvement in the product. And this is
Sorry, Mr. Manning. There's still feedback in your transmission, or is it someone else? Okay, you can continue now. You can continue.
Yes. So as I was saying, as a result of reformulation, GTUs are compatible with antioxidant medicine and can be co-administered with these two antibiotics at the Y site at these factor concentrations and moving these factor diagrams. So it makes somewhat versatile products and it makes stable in whatever diagram because we are the soil feature to stabilize to control the pH and we have the EDTA to cause the precipitation or the remove oxygen ions so that we can push for the degradation of the bioacid. So the category is pattern formation said by adding substitute and adding EDTA to enhance compatibility with application and gentamicin. People sensation is not compatible with lactate. But since that we reformulated, and this is what I can know tonight for, sensation is in fact compatible with lactate. And these are some indications progression no treatment of infections, gram-positive, gram-negatives, and similar for quite a while. What we want to highlight here is that the extreme formulation ensures of stability, whichever diet is used, making it easy for it to be dissolved, and also minimizing the formation of particles. So in summary, we want to assume being active. If you're thinking about particles in this action, think about being quality of safety My state PVT and student teacher, which civilized Nigel. These activities are actually people from acting the learning resources. Provide this to the learners, the severe criminal dysfunction, and the potential for death. And this actually shows again the safety, the lower incidences of farmers like those that have been farming in various diaries. So we can see this is sort of here, this is after, this is before, and this is after, this is before, after the brain, and so on. So, the using foundation partner matter, it increases compatibility and stability, and we formulate paragraphs in the background. It's an active, it's an antibiotic of very broad spectrum, effective, and safe for treatment of bacterial infections. So, thank you very much, and I will continue to use this for treating of infections in your patients. Thank you.
Thank you,
Any
Mr.
questions?
Thank you, Mr. Manning. That was a wonderful presentation from Facey Commodities. Thank you for sponsoring us this year. So, as we move on, we would like to now move to Dr. Walker keynote presentation. So, Dr. Walker.
Dr. Wiley for inviting me to speak. So I'm going to talk to you all about infectious diseases, a re-emerging threat. So I'll get straight into it. So there are many opportunities for global public health threats in the 21st century. And this has resulted from the highly mobile, interdependent, and interconnected existence that we now have. Rapid spread of infectious diseases, radionuclear threats, and toxins. Infectious diseases are spreading much faster now than in previous times. And because the world is so interconnected, an outbreak in any one part of the world is only a few hours away from another part. Infectious diseases, they are emerging and re-emerging. The emerging ones are basically those that have recently appeared within a population and or have exhibited rapid increases in incidence or a geographic area of coverage. They are caused by previously undetected or unknown infectious agents, known agents that have now spread to new regions or new populations, as well as the reemergence of known infectious agents. The reemerging ones are those which are now reappearing after having exhibited a significant decline in prevalence over the years. And this results from many factors that consist of a breakdown in public health control measures, evolution of the pathogen such that new genetic strains evolve, human behavior, the overuse of antibiotics that leads to resistance of organisms, population growth and migration into areas which were not previously habited, international air travel, which makes easy transmission from person to person for the infectious ones, poverty, wars, and the destructive ecological changes that have been occurring. For an infectious disease to become established, you must have firstly an infectious agent. But that agent has to somehow be able to be introduced into the at-risk population. And once it's introduced, person-to-person transmission must be readily available, must be easy. And once that disease becomes entrenched, it must be able to self-sustain within the population to wreak havoc. A subclassification of these is the zoonoses, or the zoonotic infections, which are infectious agents which pass from animal to humans. And there's an increased risk of zoonotic infections when the scenario arises where you have closer contact between humans and animal species, mostly for the reasons that I've already alluded to. When zoonotic infections occur, such as COVID-19, there's a potential for serious threats to human health, as we are now experiencing. In its 2007 report, the World Health Organization stated that infectious diseases are now emerging at unprecedented rates. There are approximately 40 such diseases were identified since the 1970s, diseases which were unknown a generation ago. And they appear at a rate of 1 to 2 per year: SARS, MERS, Ebola, chikungunya, avian flu, swine flu, Zika, and the new coronavirus. And over the past 5 years, these diseases have caused more than 1,100 epidemics. So let's look at what has happened historically. If we go back to the last century, the one that stands out is the Spanish flu, the influenza pandemic of 1918 and 1920, in which over 50 million people lost their lives as a result of an influenza A virus, serotype H1N1. In 1957 or 58, you had another influenza pandemic, this time called the Asian flu, where 1 to 4 million people died. And slightly later, 1968 to 70, another influenza A virus, H3N2 serotype this type, the Hong Kong flu, where another 1 to 4 million people died. And of course, we all know about the HIV pandemic, which began in the 80s, which has caused more than 32 million deaths and keeps rising. And at the latter end of the century, bovine spongiform encephalopathy variant CJD occurred in the United Kingdom. Within the 21st century, at the start of it, we had SARS. Just 744 deaths. Avian flu, which began in 2003. Swine flu, MERS, West African Ebola virus, and our current plague, COVID-19. So it's impossible to go through all of the pandemics over the eras, but I've just selected some just to show the damage that they have done and what was learned and what was developed as a result of these diseases. So smallpox existed for at least 3,000 years. It's a variola virus, a member of the orthopox virus family, that caused between 300 million and 500 million deaths, 500 million deaths in the 20th century, having a 30% case fatality rate. Smallpox was transmitted by respiratory droplets, droplet infection, with the early presentation being fever, back pain, nausea, vomiting. 2 to 3 days after which, you would have vesicles appearing that then change to become pustules, they then crust and fall off. Lesions are typically seen can also be seen in the nose and the mouth. And at the time that smallpox reared its head, there was no known treatment. And these are some images on the right of what smallpox looks like. Smallpox, however, gave us the ability to develop the first vaccine against a contagious disease. So the smallpox vaccine was developed, and the World Health Organization launched its plan to eradicate smallpox in 1967. And in 1980, 13 years later, it was classified as having been eradicated. However, we always have to be vigilant. So the World Health Organization maintains a stockpile of vaccines just in case of reemergence. Plague is caused by the Yersinia pestis bacterium, which is gram-negative, Coccobacillus. It's found in small rodents and is transmitted to humans via fleas. Flea bites, contact with infected material, or inhalation, droplet infection, leads to 3 different types of diseases, clinical presentations under plague. So you have the bubonic plague, septicemic plague, and pneumonic plague. Bubonic plague was responsible for what was known as Black Death in the 14th century. Again, 500 million deaths, and it's recorded the second highest caseload after smallpox. In our history, there have been 3 pandemics. The first beginning in the 6th century, the second in the late Middle Ages, and the last one in mid-19th century. And to this day, sporadic cases still occur worldwide. If untreated, it wreaks havoc. There's a death rate of between 30 and 90%, which goes down to 10% if it's treated. And the treatment is simply antibiotics. Bubonic plague is transmitted by flea bites. The bacteria multiply in the lymph nodes close to the site of infection to give these swellings, painful lymph nodes, painful lymphadenopathy, which are referred to as buboes, hence the term bubonic plague. And the constitutional symptoms that you will get would be fever, headache, and malaise. In contrast, septicemic plague is transmitted via untreated insect bites or from handling infected animals with broken skin. The symptoms and signs are similar to bubonic plague, but in addition, you can sometimes get hemorrhage and develop gangrene of your distal tissues. And on this image in the right, you can see gangrene involving the fingers and the forearm. Pneumonic plague is the most virulent of the trio. It is transmitted via human-to-human droplet infection. And it rapidly progresses to pneumonia, which results in respiratory failure and shock. Influenza is from the family of orthomyxoviruses. It consists of influenza A and B, which are the cause of the seasonal flu in cold countries that tend to run from October to May, with peaks over the middle of the winter. There's usually some immunity from previous infections and from previous vaccinations, but the viruses mutate such that they do still cause clinical disease. The risk groups for developing influenza are the extremes of age: elderly, infants, those with immunocompromised status, and chronic illnesses. Influenza pandemics occur when there's a global outbreak of a new strain of influenza A. And this arises because most times there's little or no immunity as a result of this virus not being around. So there was no previous exposure to it. When influenza pandemics develop, they cause a major public health threats. And 3 strains have been identified in the 20th century. So if we go back to the beginning of the 20th century, the Spanish flu, as I already said, 40 to 50 million deaths occurred between 1918 and 1920. And there was a high rate of fatality through a combination of a very highly pathogenic strain of this influenza A virus, H1N1 strain, coupled with the increase in travel as a result of World War I, shortage of medical personnel as a result of World War I, and the global unpreparedness to deal with this pandemic. But what it did, it demonstrated to the medical fraternity for the need of a robust public health system. Asian flu followed in 1957-58, causing 1 to 2 million deaths, H2N2 serotype. And this was the first pandemic that developed after a global surveillance system was established. A vaccine campaign was attempted, only 13 million doses were given, and the efficacy rate was reported to be between 53 and 60%. 1968 to 1970, Hong Kong flu, 0.5 to 2 million deaths, H3N2 serotype, and this disease arose as a result of an antigenic shift from the virus that caused Asian flu. However, a combination of vaccination, hospitalizations, and antibiotic treatment of superimposed infections significantly reduced the disease burden. Swine flu, more recently, another influenza A virus, H1N1 serotype, occurred in 2009 and 2010, accounting for much lower proportion of deaths, between 150,000 and 600,000. And this was the first pandemic that was dealt with by a combination of vaccination and antiviral drugs. And it still circulates in certain quarters, manifesting as seasonal flu. Chikungunya, an alpha virus, which is mosquito-borne, typically seen in Asia and Africa, but in 2013, cases appeared in the Caribbean, the Americas, and Europe. Constitutional symptoms again, fever, arthralgia, myalgia, fatigue, sometimes a rash. There's no specific treatment. Treatment is supportive, and public health control is by mosquito control, and it's rarely fatal. Zika virus is a flavivirus, another mosquito-borne illness that was first identified in monkeys in Uganda in 1947, with the first human case being detected 5 years later in 1952. There have been outbreaks in the Americas, the Caribbean, Africa, Asia, and the Pacific, and again, constitutional symptoms, rash, fever, conjunctivitis, myalgia, arthralgia, but most cases are asymptomatic. Associated with this in pregnant women, congenital Zika syndrome can develop in their offspring, which is manifested by microcephaly, so smaller than normal head, and a myriad of other congenital abnormalities. It can also induce preterm birth and miscarriages. And in those kids who are affected, there's an increased risk of Guillain-Barré syndrome, ascending neuropathy, and myelitis. There's no specific treatment, and public health measures mosquito control. SARS is caused by the beta coronavirus, SARS-CoV. It was first identified in China in 2003 and passed from person to person by droplet infection. It spread to the Americas, Europe, and Asia, but an unprecedented global response, this time we were prepared, halted any further spread. So there were only 8,000 infections, with only 1/10 of those dying, 800 deaths. The last reported case of SARS was in 2004, which was attributed to a laboratory-acquired infection. The initial phase of SARS presents with fever, headache, malaise, and myalgia. And after about 2 to 3 days, you develop cough, pneumonia, dyspnea, and low oxygen saturation. Only about 10 to 20% of cases required intubation and mechanical ventilation, thankfully. And the measures to stem its spread are the same as for COVID-19. Combination of surveillance, quarantine, social distancing, masks, and hand hygiene. MERS, Middle East Respiratory Syndrome, another beta coronavirus caused by MERS-CoV, emerged in 2012 in the Arabian Peninsula and has been reported in 24 countries throughout the Middle East, Europe, Asia, Africa, and North America. Another low case toll, only 1,000 cases, but with 400 deaths, so a significant percentage of deaths. Ebola is one of the viral hemorrhagic fevers. It's caused by a single-stranded enveloped RNA virus of the filovirus family, and there are two genera, the Marburg and Ebola viruses. Under the Ebola subtype, there are 5 species, the most significant of which being the Zaire Ebola virus, which is most common and has the highest mortality rate of all the 5, and was responsible for the first recognized outbreak. This map shows the Ebola virus outbreaks by species according to color, red representing the Zaire Ebola virus, and the size of the circles in the affected areas representing the number of cases, 1 to 10 for the smallest circle, 11 to 100 for the middle size, and 101 to 425 for the largest circle. And you could see that the caseload was confined to sub-Saharan Africa. The first Ebola outbreak occurred in Zaire in August of 1976, and patient 0, the index case, was a 44-year-old school teacher from a remote village in the Congo near the Ebola River. He was initially diagnosed as malaria and died from profuse hemorrhaging. Remember, this is one of the viral hemorrhagic fevers. The spread, the pattern of spread initially was within his family members, but it also spread to other contacts in hospital through the reuse of needles. So where does Ebola come from? The fruit bat appears to be the natural reservoir for this virus, for the Sudan and Zaire species. This virus causes epizootics and human epidemics. So epizootics is the equivalent of an epidemic, but within an animal population. Bats and non-human primates are hunted, hence humans come into contact with them. And it's believed that the epizootics or the animal epidemics may precede the human outbreaks. Outbreaks tend to occur every few years, but they tend to be limited in that same region of sub-Saharan Africa. There was an outbreak in 2014, which affected 12 countries with approximately 29,000 deaths, 29,000 cases, and 12,000 deaths. The virus is spread through contact with infected body fluids or infected animals. It's natural reservoirs, bats, porcupines, primates. Symptoms: fever, muscle pain, fatigue, nausea and vomiting, diarrhea, impaired renal and liver functions, and hemorrhage. And initially, the presentation can seem similar to malaria and typhoid fever. There's no proven treatment. It's supportive, inclusive of fluid replacement. And in 2015, an experimental vaccine was developed and used, and it was applied in an outbreak in the Democratic Republic of Congo. So let's come to the new kid on the block, the new coronavirus. This is caused by coronavirus disease 19, COVID-19, which is the SARS-CoV-2 virus. It's likely zoonotic based on its epidemiology, and as we all know, it emerged from China. It resulted in very rapid geographical dissemination because of interconnectivity and the current global pandemic. It presents as a respiratory disease, upper respiratory tract infection that progresses to adult respiratory distress syndrome as a result of diffuse alveolar damage, respiratory failure with ventilator dependency. It's similar to SARS and MERS, and there is no cure, but as we saw within recent weeks, there have been 2 counts of promising vaccine trials. To date, there have been 62.4 million cases internationally and 1.5 million deaths. It's an RNA virus, coronavirus, in which the surface of the virus has these sun-like spike protein projections hence the term corona, because it looks like radiation of a crown. And clinically, it binds to the angiotensin converting enzyme 2 receptors, which are present on type 2 pneumocytes in the lungs. Hence, it wreaks havoc on the respiratory system. It presents as fever, cough, dyspnea, but thankfully, most cases are self-limiting, but the disease can progress with age and underlying comorbidities. This is one of the early slides, which shows that you have a higher case fatality as you go up in age. At this time, there were no deaths within the 0 to 9 age group. And children, of course, that has since changed. And for the pre-existing conditions, cardiovascular disease has 10.5% case fatality ratio, diabetes 7.3%, chronic respiratory disease 6.3%, hypertension because of the ACE 6%, etc. The pathology can be divided up into what is universally agreed and some novel observations. So the universally agreed or reported findings are of diffuse alveolar damage and a viral pneumonitis, which is similar to what we saw in SARS in 2003. And in the cases that have been done at the Provincial Forensic Pathology Unit in Toronto of the Ontario Forensic Pathology Service, the OFPS, the findings in those cases have been similar to that observed in other countries. The novel observations, which can occur sometimes, are myocarditis in the heart, brain involvement, vascular pathology, and a generalized hypercoagulable state. This is extracted from publication earlier this year, The Emerging Spectrum of Cardiopulmonary Pathology in Coronavirus Disease, report of 3 autopsies from Houston and a review of autopsy findings, which shows the spectrum of changes in the lungs. You can see very, very prominent hyaline membranes, which is definitive of diffuse alveolar damage, and some of the features of viral pneumonitis. The central nervous system is not spared. Early work has suggested that the virus enters the CNS through the olfactory system, and some investigators have demonstrated olfactory transmucosal SARS-CoV-2 invasion using immunohistochemistry, as is shown in image A in the upper portal here. And then these C and D are 2 electron microscopic photographs which show the virus within cells. From a forensic pathology perspective, there are postmortem considerations. And I've just highlighted some. How long does the virus live in a dead body? It is unknown, but there's no reason to believe that postmortem, the risk of postmortem infection is significantly high. But we still take universal and special precautions. Should we conduct autopsies on known cases of COVID-19? Well, it's indicated under specific circumstances. Some people have developed research protocols to better elucidate the pathology of the disease. And you can do it on a case-specific basis if there is some compelling medical-legal issues. So, for instance, if we have a homicide and someone who is known to be COVID positive, we still have to do a full autopsy. There's no getting around from that. We apply universal and specific precautions. But in other cases, we may do a less invasive procedure. How should the autopsies be conducted? Well, it depends on the purpose. What is the question? Are you answering a medical question or a medical legal question? If it's a medical question, then you can resort to using a minimally invasive approach to prevent the risk. the greatest risk at postmortem is in the production of aerosols. So if we are to do invasive postmortem examination, conventional postmortem examination on a COVID-19 positive decedent, it has to be done in a room with negative pressure, negative ventilation pressure, with strict precautions to prevent transmission through aerosolization. So we have to use an N95 mask, and in the postmortem setting, using a rotational saw to open the chest cavity and to open the skull, that is contraindicated because an oscillating saw would produce aerosols. And those aerosols can be inhaled, so that's why we use an N95 mask. What is the current practice in Ontario with respect to these cases? Well, only the dictate from up high is that only targeted examinations will occur for strict medical legal reasons only. If someone dies from COVID-19, which is a natural disease process in a circumstance that's completely natural, so the cause is natural, the manner is natural, that case would not come the way of for a medical legal postmortem examination. Do you bury or do you cremate? Well, either is acceptable, but of course you have to have strict decontamination protocols at the end of the postmortem with respect to bagging of the body and cleaning the outside of the body bag before it's handed over to the funeral agents. There are medical legal issues associated with COVID-19. So from a public health perspective, we screen deaths in the community, which are coming from medical legal postmortem on a risk stratification basis using a postmortem nasopharyngeal swab. We are quite fortunate here in Ontario to have the resources to do it. And in my hospital, our lab, our microbiology lab could turn around a report within 24 and 48 hours. So if we have a decedent who comes in and we're not sure of what was their state of health within the last 7 days, they have not been seen or heard from, and they're found dead or they're at high risk because of their lifestyle, we would do a screening swab, sit on the case until the result is reported, and then make a decision, do we need a postmortem or not? Thankfully, in the many months since we are doing this, none of our routine medical legal autopsies in Ottawa have come back with a positive hit. The other indication would be when we have to deal with cases in which there's unclear causation. Did this person die from COVID-19 or did they die with COVID-19? Or are there some other competing cause of death? As well as quality of care in long-term care facilities. Canada has had outbreaks in long-term care facilities. These are what we would call old people's homes in the Caribbean. So you have to look at such cases because sometimes there may be allegations of neglect as well. So in the medical legal scenario, there are 3 types of cases which can be encountered. First scenario is when you have a SARS-CoV-2 positive patient, but that positivity is unrelated to the cause of death. And the Toronto unit is quite fortunate to have access to postmortem CT and MRI, so they can scan these cases and find things like hypertensive intracerebral hemorrhage, glioblastoma, etc., and not resort to an invasive postmortem in someone who's positive. Then the second category would be the fatal COVID-19 deaths in a community setting, which spans a range of ages and can occur in both those with underlying comorbid conditions that predispose them, as well as the so-called healthy individuals. And then you have the fatal COVID-19 cases in the elderly. So I'm just going to go through 2 cases. The first case is COVID-19 death in an elderly man, 77-year-old man with a history of systemic atherosclerosis, who had been exposed to COVID-19 in the community through community spread, became symptomatic, developed symptoms of an upper respiratory tract infection with progression to dyspnea and respiratory failure. At postmortem, this is what the lung looks like in its fixed state. These palish areas are areas of solidification, consolidation. And under the microscope, you can see that the mucosal lining, the epithelial lining is inflamed. There's inflamed mucopus in the lumina. On the luminal aspect, he has some evidence of chronic airway disease. There is expansion of the alveolar spaces with loss of alveolar septa. He has some hypertensive changing in the pulmonary arteries. There's some intimal fibrosis. And within the bronchioles, you have pus cells, inflammatory cells as a sign of lower tract infection. And now, at the alveolar wall level, you can just appreciate these eosinophilic bands which run on the alveolar membranes. These are the hyaline alveolar membranes, which is the result of diffuse alveolar damage, which can be the end result from many insults in the lung. And again, you can see it's much better here. You would have a lot of difficulty ventilating this patient and keeping their oxygen sats up. And yet another photomicrograph of it. Background disease, this is his kidney. There are features of benign nephrosclerosis. So you have glomerular sclerosis, hyaline arteriolosclerosis, which you get in hypertension, and it's not an unexpected finding because he had systemic atherosclerosis. In the heart, there was a band of subendocardial fibrosis as a result of ischemic heart disease. So he was signed out, primary cause of death, COVID-19 disease, with significant contributing factors being his atherosclerotic and hypertensive heart disease, as well as underlying chronic obstructive lung disease. Case number 2, COVID-19 in a healthy man, 31-year-old male, no previous medical history, presented with fever and symptoms of upper respiratory tract infection, found to be SARS-CoV-2 positive on investigation, and he developed a rapidly progressive deterioration of his respiratory status, and pulmonary thromboembolism was queried. At low power, low to medium power, you can see that there's some congestion in the alveolar vessels. This lighter pink staining material is edema fluid within the alveolar spaces. Not much information here. These are some anthracotic pigment containing alveolar macrophages. And then it gets slightly more busy, a bit more cellular. You're seeing a bit of reaction, inflammatory reaction. And then you have some proliferation of type 2 pneumocytes, more eosinophilic edema in the alveolar spaces, and you are now getting into some organizing changes here. So there was no PE, but he just succumbed, fairly healthy guy, to his respiratory infection with COVID and died. Background findings, there was a moderate to severe degree of macrovesicular steatosis in the liver. These cleared areas, spaces once occupied by fat. Fat has been leached out as part of the processing of the tissues. So he was signed out as COVID-19 disease with no other contributing factors, and that just goes to show how progressive this disease can be. So COVID-19 can progress to fatal pneumonitis or diffuse alveolar damage. How? Why? And why only in some people? These are still under investigation. The full range of pathology is yet to be determined by autopsy studies. And an open question is whether the virus infects the CNS. And as I said, early studies show that it can enter through the olfactory mucosa. The autopsy can play a key role in deepening the understanding of the disease. We are living in a very unprecedented time. And despite the advances of modern medicine, the world population is constantly under threat of new and re-emerging infectious diseases, and this is concerning for all. This current pandemic has radically changed our way of living. How long will it last? We don't know. But more importantly, what other infectious disease will follow once COVID-19 passes? So as such, medicine and science have to be concerned, and we as practitioners have to be vigilant, and we have to be our brother's keeper. I just want to, as I conclude, just draw your attention to the second annual Belize Forensic Science Symposium, which is coming up on December 16th between the Belize National Forensic Science and the University of Ottawa, under the theme, A Strategy for Adapting to Change, Aiming for Quality in a Time of Uncertainty. This is the link. It can be found on the University of Ottawa's website. Registration will soon be open, and it will consist of a host of topics and speakers that should be of interest to everyone. I would like to acknowledge as well Dr. Anton Small, who was supposed to be part of this presentation, but at the last minute we had to make some contingency changes because of the technical difficulties. Dr. Small is a budding forensic pathologist who is a senior house officer in the pathology department at the University Hospital of the West Indies, and he helped prepare this. Acknowledgement as well to Dr. Michael Polanen, Chief Forensic Pathologist for the province of Ontario and head of the Ontario Forensic Pathology Service, who was able to provide some of the case material, and Dr. Natalie Widley, Senior Medical Officer at KPH, for the kind invitation, as well as Dr. Rene Badro of the organizing committee. Thank you very much. Thank you.
Thank you, Dr. Walker. It was indeed a pleasure to hear your presentation. It was very informative as well. Really, really do thank you, and we will be tuning into your next presentation in December. As we continue with our program, we will now have our presentation by Mr. Russell from About Nutrition. So, Mr. Russell, can you share your screen, please? While we wait for Mr. Russell to have his screen up, we once again want to thank our sponsors. Our sponsors are our gold sponsor, our Abbott Nutrition, Ayelaqui, as well as Facey Commodities, PA Benjamin. We also want to thank our platinum sponsor this year, which is the National Health Fund, our bronze sponsors, which include Apex Radiology, as well as Alpha Med Global, and Imaging Intervention Associates. So, Mr. Russell, are you ready? Mr. Russell, I don't think you've connected your microphone because we're not hearing you. Mr. Russell, please, can you unmute your microphone? Okay, can you give us a minute, please? We're just waiting on the speaker's mic to be on. Once again, we'd like to thank you for your your patience, everyone. We're just waiting on the microphone to be connected for our speaker. All right, we're having a bit of an issue with our presenter from Abbott Nutrition, so we will continue to our next speaker, and our next speaker is Dr. Jason Copeland. Dr. Copeland is a graduate of the Arden High School, and after which he found that he had a serious love for medicine, and he decided to pursue his MBBS degree, Bachelor of Medicine, Bachelor of Surgery at the University of West Indies. He's graduated in year 2003. Pursuant to that, he then did his DM1 and DM2 examinations, for which now he's a consultant general surgeon at the Kingston Public Hospital. He currently is a consultant general surgeon at the Kingston Public Hospital since 2016. He also is a clinical director of breast oncology service at Kingston Public Hospital. He is also a member of several associations, include the American Society of Breast Surgeons, as well as he was a participant in the breast oncoplastic course. He also is a member of the Associations of Surgeons in Jamaica since the year 2016. He has special interests in the following areas: triple negative breast cancer disparities. So ladies and gentlemen, thank you so much. Let me introduce to you Dr. Jason Copeland.
Hi, good afternoon, everyone. Thank you, Dr. Bradrew, for such a nice introduction. I wish to thank Dr. Wong and Dr. Bradrew for inviting me to present today. I know that my presentation is a little bit off topic as I'm speaking about the Kingston Public Hospital Breast Oncology Service. So a bit of background to start with. As we know, breast cancer is the commonest cancer affecting women worldwide, and in 2018, the Global Cancer Observatory reported that there were 2.1 million cases diagnosed then. Interestingly, the trend is expected to increase. The WHO estimates that by 2040, there will be 2.8 million breast cancer cases diagnosed in that year. With respect to cancer disparity, global disparity, though 40% of all breast cancer is diagnosed in developed nations, 60% of the deaths, the mortality, actually occurs in low-income developing countries. As I've mentioned in previous presentations, breast cancer should be seen and treated as a heterogeneous cancer or a group of cancers, meaning that no two breast cancers are exactly alike. Breast cancers within different populations are also quite different. It is therefore up to us to conduct research, detailed research on our own population to look at the types of breast cancer patients that we are seeing. Some reasons for the high breast cancer mortality in low and middle income countries are such. There are patient-related factors such as delay in presentation, aggressive biology of certain tumors in certain populations, subpopulations, social-cultural norms such as fear and different belief patterns, limited education about breast cancer, and there are healthcare system-related issues such as lack of national breast cancer screening programs, limited availability of drugs, limited specialist-trained physicians, healthcare-associated delays and fragmentation in delivery of cancer care. So when we look at breast cancer in Jamaica specifically, and this is from data again from the Global Cancer Observatory of 2018, breast cancer was by far the commonest cancer in females in Jamaica, accounting for 25% of all cancers in females. With respect to deaths, the age standardized mortality rate was 23 per 100,000, and in terms of numbers, we actually had 413 deaths in 2018 from breast cancer. Perhaps more important than just the static figures is that the trend in breast cancer mortality in Jamaica has been increasing over the past 10 to 20 years, and the projection is that it will continue to increase. So the Kingston Public Hospital Breast Oncology Service was founded out of a concern for the treatment of breast cancer patients. If the mortality of breast cancer is projected to increase, and the incidence of breast cancer is projected to increase in the Jamaican population, then we need a system in place that can manage and treat these patients appropriately. The premise of the oncology service, the breast oncology service, is to allow early integration of multidisciplinary approach to delivery of breast cancer treatment at the Kingston Public Hospital. The primary goal is to decrease the case fatality rates or the mortality rates for these patients. Secondary goals would include decreasing the morbidity of treatment of these patients and increasing the overall patient quality of life. So there are three pillars that I believe are the foundations, really, or the pillars of the breast oncology service. These include research, training of doctors, design and implementation. And I'll take you through how the service came to be. So in 2017, we decided to start a breast cancer registry through the Department of Surgery at the Kingston Public Hospital. We believed that the most important indicator of the trends of breast cancer in Jamaica will come out of data from the Kingston Public Hospital. The Kingston Public Hospital is in an urban center, and in keeping with trends in the epidemiological transition of diseases from infectious to non-infectious, what happens in your urban centers will dictate what's going to happen in the rest of the country in the next 10 to 20 years. So we believe that is very important, not just for breast cancer, but that research in your urban centers, such as the KPH hospital, will dictate what is going to happen in the country in terms of trends for the next 10 to 20 years. So what did we find? Well, the first slide I'll share with you is the age distribution of new breast cancers that we saw. I've done a comparative analysis with the SEER database, and what you'll see here is that breast cancer in our population is presented significantly earlier. If you note that the age bracket 45 to 54 years, actually 38% of our patients were in that age bracket. What that says to us is that any sort of program that we're having for breast cancer has to take into account this age bracket of 45 to 54 years. What do I mean? Well, in particular, when it comes down to screening, we have to have a screening policy in place that is going to take care of this age bracket, meaning we have to start screening before that age group. And hence, screening policies that start at 50 would be inappropriate in our population. More likely, screening programs starting at age 40 will show the greatest benefit for us. And that's the importance of understanding your own population and doing research on these populations. So this is a pie chart that is depicting the molecular subtypes of breast cancer that we found in the KPH registry compared with what they found in the SEER database from the USA. And what jumps out at you is that the luminal A breast type, that estrogen receptor positive breast type that has very favorable prognosis, accounted for 66% of their overall population. In our population, it was only 49%. So we are seeing less favorable breast cancers in our population. Significantly as well was that triple negative breast cancer that you'll see here in a bit of a burnt orange accounted for 21% of our patients. In the SEER database, it was only 10%. So we are seeing twice the rates of triple negative breast cancer, which is the more aggressive type of breast cancer, and we're also seeing lower rates of hormone receptor positive, which is the least aggressive type. Further analysis, I looked at the grading of breast cancer within our population. And what jumps out at us is that in the SEER database, they had 21% of their population having low histological grade breast cancer, i.e. a favorable type, while in the KPH data, we only had 8% having a favorable type. When we broke it down into age bracket subgroup analysis, we found that patients under the age of 50 years, none of those patients presented with low-grade breast cancer. So they did not have that favorable histologic grade at all once they were young. So to summarize the research from the KPH breast cancer registry was that all patients were younger, had more aggressive biology with respect to their grade. They also had higher triple negative breast cancer rates, which is a more aggressive form of breast cancer, and they presented at a generally later stage. So from the get-go, what we're finding is that we have a patient mix that has more aggressive cancers, their clinical pathological features indicate a poor outcome, and they're being put in a system that is rather fragmented in terms of how we deliver healthcare, cancer care specifically. I would like to acknowledge at this point the residents who worked tirelessly on the KPH breast cancer registry. Dr. Powell, Dr. Oediji, and from the medical records department, Mr. Gooden. So we completed the research and we saw that we are seeing cancer patients, breast cancer patients with a poor biology. So we needed to find a way to enhance training of the medical personnel to treat these patients. I was always interested in breast cancer care and the options for training, and I'll say this to any young surgeons who are looking for oncology training options. The Royal College of Surgeons in Australia is an option. The Royal College of Surgeons to the UK is an option, and the Society of Surgical Oncology to the USA. For myself, the Society of Surgical Oncology, they were actually quite impressed with the KPH registry and offered a fellowship to be trained there. The fellowship was done through the Roswell Park Comprehensive Cancer Center, which is in Buffalo. And there they have 5 dedicated breast surgeons and see over 1,000 new breast cancer patients annually. So let's talk about the design and implementation phase of the Kingston Public Hospital breast cancer service. Breast surgical oncology, by definition, is a subspecialty of general surgery. So the breast oncology service was born out of a subspecialty area of general surgery. We want to focus, however, on a multidisciplinary context. So the plan is to have medical oncology, radiation oncology as part of the primary service delivery, and also to include adjunctive services such as plastic surgery, physical therapy, etc. There is continuous change in how breast cancer is understood, both locally and globally. This is an opportunity for us to incorporate research into the breast oncology service. In designing the service, I used a national accreditation program for breast centers in the United States, published in 2014. Now, any breast center that is being established in the USA has to use this sort of manual as their framework. Now, I will not go through all of the different components, but I will highlight a few for us. With respect to imaging, currently, we do not have mammography at the Kingston Public Hospital. This is a critical component of what we are trying to establish as part of the breast oncology service. It facilitates detection of breast cancer, lesion localizations for non-palpable cancers, surveillance, as well as screening. Now, I would like to acknowledge Dr. Anthony Roberts, who has been leading the charge in trying to procure a mammography unit and leading a lot of the coordination and meetings for this program. With respect to ultrasound, similarly, we do not have a dedicated ultrasound unit for the breast oncology services yet. It will facilitate diagnostic procedures, biopsies, intraoperative use such as margin assessment, wire localizations, and even the use of radioactive lesion localization. These are equipment that we need immediately that can actually change how we can deliver breast cancer care. I've been speaking extensively with the pathology department, and I'd like to recognize Dr. Stennett, who's been working with us, because what we're trying to do is to decrease the time to getting back these histological diagnoses from our biopsy specimen. Also, we need to incorporate early the results of immunohistochemistry. Traditionally, a lot of our patients would come with a diagnosis of breast cancer, be treated by our surgical team, and then the immunohistochemistry comes back after surgery and only in time for the medical oncologist to see the patient. What we are trying to get done is to have everything up front for these patients to be involved in the decision making. I'd also like to highlight here genomic testing or the use of genomic equations. A lot of our patients with breast cancer, especially those that are estrogen receptor positive, may benefit from de-escalation of chemotherapy provided that they have low genomic testing scores. It's an expensive venture, but for the genomic testing, but the use of the equations is actually free. Now, if we can incorporate this in our pathology, we might be able to decrease the use of chemotherapy in some of our patients in which chemotherapy would not be beneficial. Specifically to the surgical oncology side, what we want to do is to have timely access to oncologic surgery, but this access to surgery should be appropriate. What I mean by that is that there are some patients, again, who present with breast cancer who will benefit from a multidisciplinary assessment and the introduction of chemotherapy rather than going directly to surgery. Some of these patients will include patients who have triple-negative breast cancer or HER2-positive breast cancer, where the opportunity is there to treat these patients, look at their response and their residual tumor burden, and based on that, we can decide if additional systemic therapy will be necessary. Now, if we take these patients to surgery up front, we would miss the opportunity to assess their response to systemic therapy, and that patient has lost the opportunity for that assessment to be done. We also want to decrease the morbidity of surgery, especially in patients who have early breast cancers, by de-escalating some aspects of the surgical therapy. For example, the use of breast conservative therapy, oncoplastic breast conservation, nipple-sparing mastectomies, sentinel lymph node biopsies rather than axillary lymph node dissections where appropriate, and incorporating more post-mastectomy reconstructions. Part of the KPH registry had actually showed us that only about 5% of our patients were getting reconstructions post-mastectomy. And this is part of the importance of incorporating the plastic surgeons early in the decision-making process, that we can have direct to implant reconstruction or immediate reconstructions with expanders. I'm going to present two cases. Now, the service was started about 4 weeks ago, and in that time, we've done about 4 operations. This patient presents with a 2-centimeter lesion in her right breast. She has no palpable lymph nodes, and she has a favorable molecular subtype. She was hormone receptor positive. Now, she was very much interested in salvaging her breast, and previously, this is a patient who might have gotten a mastectomy with axillary lymph node dissection. What we found is that this patient was quite amenable to breast conservation therapy, which would include a wide local excision and post-excisional radiation therapy. You'll notice that there's a wheal in the periareolar region, and that is actually the injection of a radioactive colloid. And we use a gamma detection probe to identify hot lymph nodes marked by 3 dots in our right axilla. We opted for an axillary incision, which would prevent us from having to put a scar on the actual breast itself, dissected medially towards the nipple, and we excised the lesion with a rim of normal tissue around it. The excision was taken right down to the pectoral fascia, and the sentinel lymph nodes were actually taken out through the same incision. This is the specimen here, and it's marked for orientation anteriorly, lateral, and superiorly. That's a gamma detection system and 3 sentinel lymph nodes that we took out. This is a second patient who we're planning to operate on in a few weeks' time. Now, this patient, as you can see, has macromastia. She was actually symptomatic of her macromastia, but she also has a lesion in her left breast. Now, you can't see this lesion, but it's actually about 5 centimeters in size, and she also has clinically positive axillary lymph nodes. Now, obviously, treating this patient with a mastectomy would leave her very much asymmetrical, and to be very difficult for this patient in terms of having one large breast on the right side and a flat chest on the left side. She was also interested in breast conservative therapy. Now, with her large lesion on a positive axillary lymph node, we've actually asked the medical oncologists who were in our clinic to see this patient early, which they did, made an assessment, and has brought forward her opportunity to be treated with neoadjuvant chemotherapy. The plan here is to offer neoadjuvant chemotherapy to reduce the size of the lesion within the breast, and will allow us to actually do a reduction in this patient of both breasts, remove the cancer on the left side, and leave her with smaller, more manageable breasts, and to correct her ptosis that she has here. So in this patient, we can actually reduce both breasts, lift the breasts, and take the cancer out at the same time, for which she's very excited to have done. The medical oncology team has been working closely with us in our breast oncology clinic. It's an opportunity for all our patients who require chemotherapy to be seen or to have their initial assessment done in our clinic. They are next door to us, and it allows us to have that multidisciplinary talk about all the patients that we see as they come into the clinic. If they need to be seen by the medical oncologist, they're seen right there, right then. It has reduced the time to adjuvant therapy, and has also reduced the time to neoadjuvant chemotherapy. Again, I'll mention that there's an opportunity here for selective de-escalation of chemotherapy in some patients who have a favorable molecular subtype. Similarly, we know that radiation therapy in patients who have metastatic disease to their lymph nodes actually decreases or improves the overall survival and decreases the recurrence rate of cancer in these patients. Again, we have radiation oncology in our clinic, and we're working closely with them so as to expedite access to whole breast radiation therapy or access to regional nodal radiation therapy or palliative therapy if indicated. I also want to mention here about patient navigation. Now, patient navigation is a critical component of what we're trying to do through our medical, to our oncology clinic. The premise behind patient navigation is that it's an interventional strategy where patients, we can break down the barriers to care for these patients by eliminating the time it takes for them to go to one service, then another service, and then another service. When it comes on to getting patients' results, what we have done is established a single email address that radiology companies and others can actually send some patients' results to this email address rather than having the patient go and collect the results themselves. Our nurse oncologists also book these patients in the different clinics, coordinate with the different clinics, and ensure that the patients are there. If patients are missing, then we can call these patients to find why they did not make their appointment, and it is a much more seamless system for the patient. It's a critical component of how the patient moves through the system with less frustration. Registry and research. We have maintained the KPH registry protocol that we had from 2017. We have improved it in some areas, and this has provided us with certain opportunities for research. In particular, we want to look at patients with locally advanced breast cancer and the impact of neoadjuvant chemotherapy. We want to look at breast cancer staging in Jamaica because a lot of our staging recommendations actually come from North America. We believe that there might be differences in staging recommendation for breast cancer patients in Jamaica compared to North America. Obviously, we have 21% of our patients have triple-negative breast cancer. This is another important opportunity for research. And also breast cancer genetics. The fact that we have so many young patients and triple-negative breast cancer will likely lead to the finding of increased breast cancer mutations if we are testing. In the public system, we do not have access to genetic testing, but we're trying to get some pilot projects off the ground where we can actually have genetic testing done. There are a lot of opportunities for collaboration and research, early detection and screening with the Jamaica Cancer Society, patient education, funding. As I said before, research at the Kingston Public Hospital has to be a major component of healthcare policy, and we have a lot of opportunities to establish funding relationships, I think, with private sector and overseas organizations where it comes on to breast cancer care. Partnerships with companies, such as some of our sponsors who are here today, who have been providing care in different ways for breast cancer patients. For example, the ALIQ partnership, where we're trying to get implants available to KPH patients. Other partnerships, such as those having to do with the provision of chemotherapy ports from IRAD, and a few others that are on the ground. Research grants, we believe, is an important component of the oncologist service, that we can actually do proper research to better understand what we're seeing at KPH. Training, not just for physicians within the service, but also for residents who need to rotate through the service to have a comprehensive understanding of breast cancer care. Also, the establishment of survivorship groups. This was October 27th, the first day that we had our clinic, and I'd like to say thanks to the SMO, Dr. Wiley, who has been instrumental in supporting this project. On our first day, we had Dr. Marvin Norman, the first resident, rotating through the program. We also have Nurse James, who is our oncology trained nurse. She's our patient educator. She's our patient navigator. We also have myself, Mr. Stevens from the region, and Dr. Anthony Roberts, who's the other surgeon in the oncology clinic. This is a message that I actually got from one of our nurses last month during the Breast Cancer Awareness Month. And I've shared this with a lot of my breast cancer awareness presentation audience. where pink is worn to raise awareness and to break the stigma for women and men, because breast cancer occurs in men also, who have fought the fight and are fighting the fight, and the family members who are supporting them. Together we can enhance the awareness and contribute in this fight. Our few acknowledgements. The Medical Oncology Department at the Kingston Public Hospital, the Radiation Oncology Department, the Regional Technical Director, the SMO, the residents who have rotated through the program so far, Dr. Peters, Dr. Green, Dr. Coombs, Dr. Norman, Dr. McKenzie, the surgeons who are in a part of the breast oncology service, Dr. Roberts, Dr. Cherry, and Dr. Price, who will be rotating through, Dr. Simpson, who is the HOD of the Department of Surgery, who has been very supportive in this project, and all the surgical firms that have been referring patients to the clinic. Nursing staff, Sister Buckley was very instrumental in getting this project off the ground. Nurse James, who's our nurse oncologist, and all the other members of the surgical nursing team. Also to Dr. Appiah from plastic surgery, Dr. Sten from pathology, Dr. Palmer and Dr. Elvis Brown from radiology, the medical record teams, and the information technology teams. I'd like to thank you all and thank you very much for your attention. Thank you.
All right, we just want to thank Dr. Copeland for a very interesting presentation, and we do want to commend you on all the work that you're doing in the oncology unit at KPH. We will continue our conference, and our next presenter would be Mr. Russell from Abbott Nutrition. Can you share your screen, please? Mr. Russell? Mr. Russell? Are you able to share your screen? Okay, so now we're seeing your screen, but we're not hearing you. Can you unmute your mic? I think we'd have to just go to another presenter in the meantime. Can we have the presenter from the Caribbean School of Medicine?
I am here. Okay.
Hi, Mrs. Hyde. So I think we're able to hear you. We're just waiting on your presentation to come up. Can you share your screen with us, please? Well, share your presentation, sorry. You would also need to close the YouTube page because you would have a feedback. Sorry, Mrs. Hyde, you have to close it. You can't minimize it and have two screens at the same time, the same thing. So close it completely. Great. Okay.
All right.
Yes, now you can start your presentation.
You see my screen? Okay. Okay, great. No, but I can't see my screen. Hi. Conference organizers, moderator Dr. Badu, and participants, present, good afternoon. My name is Daniela Hyde. I am the registrar at the Caribbean School of Medical Sciences, Jamaica. The Caribbean School of Medical Sciences is a chartered institution with the government of Jamaica, with specialization as a medical education and healthcare and science training institution. We started in 2015 by a team of Caribbean nationals, and we have been in operation since. We go by our motto, knowledge, competence, and humanity. The Caribbean School of Medical Science is currently located at 15 Burma Avenue, Kingston 10, right here in Kingston and St. Andrew in Jamaica. Our philosophy at the medical school is to impart the highest scientific and clinically ethical education and knowledge to our students. The school employs the right condition and an ambience for maximum academic standards to produce graduates who are exemplary medical, science, and healthcare practitioners in the art and science of medicine and healthcare training, to become excellent researchers and practitioners of lifelong learning. Our students are trained to be humane and sensitive to the cultural norms and protect the citizens' rights within the society in which they will work and reside. Our mission is to train scientifically prepared, technically skilled, clinically competent, and humane students in the practice of medicine in their pursuit of becoming a medical doctor, and of course, other healthcare professionals. They will employ the principles of science, healthcare relationship, and maintain confidentiality in the discharge of their duties. Now, CSMSG has been around since 2015, and we can boast some successes thus far. We are registered by the University Council of Jamaica, the Jamaica Tertiary Education Commission, Ministry of Education, Youth and Information. Our students now have access since 2015 to the Student Loan Bureau loan packages. We are, of course, a chartered institution since 2017. And we have boasted a program, or 4 or 6 weeks CAMC review program with a success rate of 95% for all the candidates that have gone through the program thus far. We have a gazetted anatomy lab by the gazetted through the Ministry of Health and Wellness. And we have also secured clinical rotation spaces here in Jamaica, the US, and Cuba. This year is a very big year for us as we successfully graduated 3 medical students. They are now interns at Maypen Hospital and Cornwall Regional Hospital. We have also partnered with the Royal College of Physicians in Edinburgh and have hosted over 10 symposiums offering CPE credits. Here in Jamaica, with our outstanding physicians, natural and applied science teachers, healthcare professionals, researchers, and the opportunity for clinical experiences, and especially the proximity to the United States of America, we are known as one of the best locations in the Caribbean basin for medical education. And we have continued such a success here in Jamaica by hosting many symposium and seminars. The aim of the Caribbean School of Medical Sciences is to train top-of-the-line physicians to pass the USMLE exams, PLAB, MCCQE, the CAMC, and to practice anywhere in the world that they so desire. And of course, continue to contribute to emerging economies such as Jamaica. At the Caribbean School of Medical Sciences, we offer an MD program. Our MD program is a 12-semester, 4-year Doctor of Medicine degree, where students focus in the first 2 years on basic sciences and the latter 2 years, year 3 and 4, on their clinical rotations, which they can successfully do here in Jamaica, Cuba, and the US. We also have programs, specialized programs in sports medicine, health tourism, health technology, and of course, tropical medicine and public health that we offer within the Faculty of Medical Sciences. We also have our 16 months, 4-semester Natural and Applied Science degree, which is our pre-med program. We have also successfully been doing a 6-week CAMC review program over the last 4 years. This program is aimed towards local medical interns who would like to pass the exam but would need some additional help because maybe they are coming from countries outside of Jamaica, and they would probably need some assistance in successfully passing the CAMC exam. And we have been very successful at assisting these students in these exams. We also offer a 4-week review program for students who are interested in passing the USMLE exam. This is done through partnership with PASS program and Kaplan International. At the Caribbean School of Medical Science as well, we have great facilities. We have a library equipped with online and face-to-face resources for our students and faculty. We also have anatomy lab equipped with state-of-the-art technology and equipment to assist the learning of our students. We have great facilities such as our lecture hall that can host up to 100 students and faculty for any event that we are having. Okay, so we are located again at 15 Burma Avenue. We can be contacted at 876-929-6422, as well as our mobile number 544-6402. And of course, our email and our website. Thank you very much for allowing me to do this presentation in your forum. Thank you.
By P. Benjamin. Mrs. Bennett, can you share your screen, please? Mrs. Hyde, can you please stop sharing your screen so we can have the next presenter?
How do I stop share?
Just click the share button. Okay, thank you so much. So our next presenter is from P. Benjamin. This is Miss Andreen Bennett, and she'll be just giving us an overview of her company.
Hello, good afternoon, everybody.
Hi, good afternoon, Mrs. Bennett. Can you put your presentation on presenter mode?
Okay. Is everybody hearing me?
Yes, we're hearing you.
All right, good afternoon, everybody. I'm Andreen Bennett, Marketing Manager from P. Benjamin. And this evening, we're pleased to be a sponsor of the KPH conference. And we'll be just giving you an overview of our company. Benjamin has been around for over 100 years, and we're part of the pharmaceutical industry. We entered the cough and cold industry in 2007, and I'm going to go through just a few of our products here today, so that's just to familiarize you with our products. Okay, so I'm going to look at our asthma relief syrup. It has in it, it contains salbutamol. It is excellent in the relief of bronchospasm associated with asthmatic symptoms. Example, coughing, wheezing, and shortness of breath. So these are actually prescription drugs, prescription products. These are not available over the counter, and it has to be prescribed. So we have that is our asthma. I'm trying to go to the next slide. And then we also have our asthma relief expectorant syrup. It's excellent in producing expectoration due to mucus hypersecretion in asthmatic patients. And then we introduced our relief line for cough and cold in 2007 in this new packaging. The relief elixir it relieves running nose due to colds and allergies. It's available in sugar and alcohol free. So even the young ones can take it because it's alcohol free. And it's available in different flavors, cherry and grape. And we have our relief expectorant. Contains diphenhydramine, ammonium chloride, sodium citrate. It relieves chest, colds, and coughs. It's excellent for entire family, 2 years and over. And just like elixir, it's available in sugar and alcohol free, and it's available in different flavors, cherry and grape. And for the kids, we have the fever and pain. So, at this time when we have a surge in dengue, this is a very good product for the kids. It relieves fever and pain. It has an excellent taste. It's sugar, alcohol, and aspirin free. So you see, Benjamin's has a products for everyone to help you. Now, our sinus relief sinus is a very good product line for sinus, very effective. I've personally taken it myself, and it's very, very good. It's proven effectiveness. It's sinus and allergy relief. It contains pseudoephedrine, chlorpheniramine, and paracetamol. And then we have our cough and cold, which contains ingredients as the sinus, and it's excellent allergy, cough, and cold relief and proven effectiveness. So what I'm going to do here is actually our new packaging. So this actually was changed in the past couple of years. So the shelves used to have the old packaging. Now we have the new relief packaging. And we know Benjamin's is a trusted name for over a century. So, we pride ourselves, we're ISO 9000 certified, and we pride ourselves in the quality of our products. So these are products that can be, introduced to your patients, and it's very effective. And we have the flu. So we also have products for flu, which relieves nasal congestion, allergy, pain relief, fever reducer, and it relieves flu, of course. This is our flagship at this time in terms of our honey time. It's an old Jamaican remedy in a taste of honey syrup. It has honey, rum, and lime, and it also has vitamin C, and it gives you that vitamin. Now that persons, especially in COVID now, when persons are looking to have vitamin C, this is a wonderful product, and it has been doing very well for us, especially at this time. It's available all across the island. They also have infant care, so infant gripe mixture, the kids, it's excellent to the relief of acid indigestion and discomfort caused by teething in infants. This is one of our product lines for kids. So you see, we have product lines for all, the entire family. And we also have our antacid. So we have our magnesium trisilicate mixture, which is this is an older product, in terms of, you'll have the persons in the older age group will be picking up this off the shelf because they're more used to this one. But we also have our new Benjamin's antacid anti-gas, which is a peppermint flavor. So we have these two lines two products here for stomach protectants. It's effective relief of acid indigestion, heartburn, hyperacidity, and gas. And we have our worm tablets. So, at the time when it's back to school, when parents would like to give their children some worm tablets, we do have worm tablets also. So you see, we have products for all ages. We have products for the entire family, and that is Benjamin's. And we also have the topical antiseptics. We have Benjamin's mercurochrome, tinge of iodine. We have all these products available as antiseptics. All our products are formulated in accordance with the British Pharmacopoeia. It's proven to be effective in treatment of cuts, wounds, and bruises, and it's extensively tested against microbeads. It's safe for use in open wounds. So these products have been around for over 30 years. So Benjamin's have a wide variety of products. Our products are available across the island in pharmacies, supermarkets, wholesalers across the island. Our prices are competitive and affordable, and our packages are very attractive and on the shelves, and most are over the counter. So that is Benjamin's. We can be contacted. Our address is at 95 East Street, and our website is pabenjamin.com. So more information, our products are actually distributed by Facey Commodity at Newport West. So we're available all across the island. So that's it from me for Benjamin's. Enjoy the rest of the day, everybody.
Thank you, Mrs. Benin. Thank you very much. We will now continue our program with our special presentation. We invite Dr. Natalie Wiley, or SMO, to make the presentation for us.
Clinical Research Conference at the Kingston Public Hospital, to our new conference chair, Dr. Renee Badro. Today has been a bit challenging. We know we have had some technical difficulties, but I want to applaud you, Dr. Badro, for pushing through and for making the conference a success. Thank you. So on behalf of the team at the Kingston Public Hospital, thank you so much for your stewardship, and we know the lessons learned we will put forward to next year. So thank you so much for your efforts.
Okay. Although I'm the chairperson of the committee, that was a complete surprise. And I just want to say thank you to everyone for that, gift and token. Thank you so much. We're still not finished. We have just a little way to go. Mighty long way we've gone so far. And we're going to have the presentation by Mr. Russell. if he is now able to connect. Mrs. Bennett, can you please unshare your screen? Mrs. Bennett, can you please unshare your screen, please? And Mr. Russell, are you able to connect? Still not on? Someone has their microphone on. Can you please mute yourself, please? Mr. Francis Smith, can you please mute your microphone, please? All right. All right. We're going to just move on to a special presentation by Baringo Ingleham.
COVID is important, but actually heart failure is important too. Heart failure doesn't go away because there is COVID. It stays there, it is there. Your patients do have problems. They have diabetes, they have renal problems, and really deteriorate over time despite all the other things going on. So we need to have better care for these patients. And I have the pleasure now to give you a little bit of some additional information. You heard already that I'm working in Berlin at the Charité Medical School, and I'm involved in therapeutic research. I'm involved in heart failure, many interesting things that we are doing there. But one of the most interesting things I'm involved in is the very big trial program testing empagliflozin for patients with and without diabetes and having heart failure with reduced ejection fraction and preserved ejection fraction. And this trial program will come to an end in the next 6 to 12 months, and we will show you then the real results. And my presentation today is giving you the background of why all this was developed, why we are doing what we are doing, and what to expect maybe from all of this. These many trials took place internationally for the various different therapeutic classes. And some of these trials are actually just finishing as we speak. If you see on the very right, the very last red box, which is ertugliflozin and the VERTUS study, and I will come back to this during my presentation. It's an important study, despite not being successful, but it tells you something about the overall class of medicine. These trials are really shaping the future of our understanding. Why was it that these trials were developed in the first place? Because cardiovascular outcomes were actually increased by some of the anti-diabetic medicines of the beginning. Then there was the need to establish cardiovascular safety. And after cardiovascular safety was established, a few of these medicines also showed cardiovascular improvement. And this is what we are talking here about today with the SGLT2 inhibitors, which is the EMPA-REG outcome study. It was a 3-arm study, 7,000 patients included, and these patients were tested for a reduction of 3-point MACE. MACE basically meaning events of mortality, non-fatal infarct, and strokes. And these kind of endpoints were assessed in patients who had cardiovascular disease already established and had type 2 diabetes. Now, interestingly, and this will be later on very important, this establishment of cardiovascular disease did not include heart failure, which is the main reason that we did separate heart failure trials, because heart failure patients were not primarily covered in these early trials. Now, when you then look at EMPA-REG, you see here a 14% reduction, and the two different doses had very similar efficacy with this. This was significant. But when your overall result is significant, you can actually then look beyond and look, for instance, at all-cause mortality. And here you can see with the two different doses shown separately that each of the two doses of empagliflozin had a 30% reduction in all-cause mortality. Huge benefit, and this is something that we started off by saying we want to give people lifetime back. This is giving back lifetime. Because the success was so similar with 10 and 5 milligrams, we have now decided to do all future studies only with the 10 milligram dose. Now, you want to understand the mechanisms of what you really prevented, and cardiovascular death was the predominant reason why all-cause mortality went down. There was a 38% reduction in cardiovascular mortality over time, and you can see that the separation of curves was very early on. Already after 3 months, this was a significant result, and the categories of death that was reduced encompass everything that is possible, from acute MI as a cause of death or stroke, cardiogenic shock, sudden death, worsening heart failure. All of this went down and together produces this 38% reduction of hospitalization for heart failure in a cohort that had very little heart failure to begin with. Only 10% of patients in EMPA-REG in the beginning had an indication by the clinicians investigating these patients that there was heart failure to begin with. It was strongly reduced, so that means prevention of future heart failure is possible with these medicines. So now you have kidney benefits, heart failure prevention benefits. What about the subgroup of heart failure patients itself and these different endpoints? Here the data from EMPA-REG, and you can basically see that when you had heart failure at baseline, you have very similar benefits across different kinds of endpoints in terms of the overall point estimates, very similar compared to the cohort of patients having no heart failure. So this is very reassuring for the future. So let me take a first summary. We have maybe with looking at dapakana and empagliflozin as the leading SGLT2 inhibitors, you have a modest improvement in MACE events, but not dramatically strong. Cardiovascular mortality only reduced with empagliflozin, but heart failure hospitalization and renal effects are reduced with these medicines altogether. So this means for some things you have similar effects, but for others you don't. And if you remember also ertugliflozin not being successful for MACE. So overall, we need to say each trial group and each drug group needs to be looked into specifically. Now, of course, we are here to talk about the heart failure patients. So we are now doing this in heart failure patients. We are doing this in heart failure with preserved ejection fraction. There are several trials ongoing, particularly the Emperor HFpEF and the DELIVER trials are very much the key information coming out in 2021 that we are all looking for. I have the pleasure to chair the Emperor HFpEF trial, and this trial will report in the first quarter of next year, and then we know how 6,000 patients with HFpEF respond. But we already have some great news, and this is coming from the heart failure with reduced ejection fraction space. We now know that DAPA-HF does work. I will show you the results in a second. And at the ESC meeting in 2 months, we will learn how in the Emperor reduced trial this is looking like. we're very much optimistic that empagliflozin reduces important bad events for heart failure patients with reduced ejection fraction, and maybe even more so than seen in DAPA-HF. So I told you already, the Emperor reduced trial, which is up to 40%, will present at the ESC, and then the Emperor Preserve trial with 6,000 patients in the end recruited will report at the ACC 21 study, kind of late-breaking presentation session. And so we are really looking forward to share with you in the near future the results, but we are very, very optimistic. So how is it looking like from the guidelines right now? Now, the heart failure guidelines, they were written in 2015, published in 2016. At the time, we only had the EMPEREX study. So yes, empagliflozin is for prevention of heart failure. We now basically extend this in the most recent consensus recommendation that also canagliflozin and dapagliflozin can be used for prevention of heart failure. And there is no specific recommendation yet, but with the EMPEROR reduced trial, together then with DAPA-HF, we shall be able to really make a very good judgment whether SGLT2 inhibitors, particularly empagliflozin and maybe then also dapagliflozin, can be the best drugs to early start in heart failure patients.
Okay, and that was our presentation by Baringo Ingleham. We will try once more for Mr. Russell, if you're able to just load your presentation for us quickly. Mr. Russell will be presenting on behalf of Abbott Nutrition. Mr. Russell, can you speak now, please? Give Alfred a walk, please. Give Alfred a walk. All right, we'll just have to proceed. We had a question for Dr. Walker, but I'm not seeing that he's on right now. He probably has gone to do something. So we just want to bring this meeting now to a close. On behalf of the KPH Research Conference Committee, we'd like to thank everyone that played an instrumental role in making this conference a success. We want to thank our presenters. we really do appreciate the time that you took to get your presentations ready and prepared and showcasing what KPH has to offer Jamaica, not only Jamaica, the world at large. We also would like to thank our sponsors. Our sponsors include our platinum sponsor, National Health Fund, our gold sponsors, AA Laqui, Beringa Ingleham, About Nutrition, Basic Commodities, Caribbean School of Medical Sciences, PA Benjamin. We also want to thank our bronze sponsors, Apex Radiology, Imaging Intervention Associates, and AlphaMed Global. Thank you so much for supporting us all throughout the years. We also want to thank the hardworking committee behind the conference, our IT personnel, our coordinator, Mrs. Myers, or other workers, Miss Hobbs, Miss Hobbs, Miss Karine Somas Brown. Thank you so much. Anybody I failed to mention, Miss Black, thank you for coming. Anybody else, Dr. Wiley, everybody, Dr. Wong, thank you for always being here. Anybody else? Everybody I have mentioned. Thank you so much for being a part of the KPH Research Conference. Thank you for helping us. And we will see you next year. Face to face, hopefully, and also online. All right, have a blessed Sunday.